خلاص خلاص. تشيك الصوت ولا مفيش صوت؟ في صوت صح؟
هو في صوت بس سيء.
انا لايف عامة اهو. اللي بتميل صح؟
طب احنا اعمل لهم ميوت هما الاثنين دول. انا عامل ميوت لنفسي اهو، ممكن اعمل ميوت.
شوف في ايه؟ يخفيني.
Clinical or academic departments that used to have their annual congress alone and single-handed. The visibility within the faculty, within the academia was not enough. That's what I believe by that time. So the decision was to try to get everybody together on board. A sort of multidisciplinary, interdisciplinary, medical week, uniting all departments together to see each other, to share ideas, thoughts and insight with each other, not only within Ain Shams Medical College, but with their peers in Egypt, all sister faculties of medicine in Egypt, in the region and globally. And that's why we are very keen to host our friends and colleagues from around the globe, from the west and east, from the north and south, to share with us their thoughts and ideas and experience, and to end this week by MOUs, by partnering, by any sort of agreements for future collaboration, including training for nursing staff, for doctors, for young doctors, for even attending doctors, for paramedics, for research above all, and for joint international publication. One of the good things that we did over during the past few years also is to raise a dedicated medical research unit or department called MASRI, which is concerned with basic research, translational research, and clinical research. And I believe it's a very good platform for our colleagues in Ain Shams University and their colleagues and peers from different disciplines to work together and to showcase all their work and experience in a sort of joint publication to the whole world. Coming to numbers, I believe that this 41st annual medical week in the premises of Ain Shams Faculty of Medicine that will start on the 21st and goes until the 27th. I hope that I can see you, at least with some of you physically, by the end of this week. Participating 10 academic and 20 clinical departments all together, with invited 25 guest speakers and 7 working days and up to 126 total working hours. And this has been accredited by the European Accreditation Council for Continuous Medical Education. I cannot end my word without touching on what we all are witnessing in the world over the past, I would say, 1 year nearly now, since December 2019, when the COVID-19 pandemic hit the whole world very hard, I would say, without any exception. And I think this was challenging to all of us. One of the challenges that we are meeting today, and that we online, and we are doing it more or less virtually rather than physically as we used to do. But I think within the challenges that we all met over the past year, there have been some opportunities. One of them is the marked advancement, and thanks to the IT and technology, that we are more and more on webinars, daily and hourly webinars, virtual meeting, exchanging expertise. It didn't stop us in the academia, whether when it comes to e-learning or hybrid learning or any sort of acquiring skills. Obviously, we need physical existence, and we need physical meeting face-to-face for certain skills and for certain experience to be shared and to be exchanged. I'm sure that it will not be for long, and we will soon have more than one vaccine in the globe and an accurate treatment for the COVID-19. And I wish you all the best, and please stay safe. Thank you very much.
It's my honor to announce the 41st Annual International Ain Shams Medical Congress. It's Ain Shams Medical Week named Towards the Access to Innovation. We have participating departments, 10 academic and 20 clinical, esteemed 25 guest speakers over 7 working days. We have also 126 total working hours. On the behalf of the Faculty of Medicine at Ain Shams University, I hope you first best of health in the current COVID pandemic, which despite its negative effects has empowered us to exert more efforts to reach and collaborate with many participants all over the world through webinars, and we are offering free registration to include the maximum number of junior staff all over the world. I'm looking forward to hear feedback from all the participants at the closing ceremony. I would like also to know your conclusions and recommendations. I hope to meet you all next year at the premises of Ain Shams University after the end of this pandemic. Thanks for all of you.
It's a great pleasure to welcome you all in the 41st Annual International Ain Shams University Medical Congress. We prefer to call it Ain Shams Medical Week. I want also to welcome all our guests from abroad who are joining us thanks to the technology and the internet. I'm really grateful to the president of the university, Professor Mahmoud Al-Metaini, and the dean of the Faculty of Medicine, Professor Ashraf Omar, for their continuous support and encouragement all through the preparations. I want also to thank my colleagues, heads of departments, all the staff, whether seniors and juniors, who put the effort to make the Congress and who prepared the sessions, which I hope to be really fruitful and rich sessions. Thank you to the sponsoring companies who supported the Congress. I have special thanks also to IRIS, the organizing company, Dr. Ashraf Badawi and his team for always being with us in all events. It was really a tough year. 2020 was not a usual year. It was very special. We had lockdowns. We had travel were banned. We had even the gatherings, even the family gatherings were not allowed, which made us all somehow isolated to some extent. So I want to express that I'm really glad that now we have the chance to meet again, even through the internet, but still we can communicate, we can share our experiences. We can introduce our researches, our results, everything that we did this last year. I really wish a fruitful session, a fruitful Congress as a whole, and that each session to have a meaning. Thank you and wish you all the best.
It's my pleasure to welcome you to the 41st Annual Ain Shams University Medical Congress that will be held between the 21st and 27th of November. There are 10 academic departments and 20 clinical departments participating this year. Because of the COVID crisis, this year is not a face-to-face experience, it's rather a virtual, unique experience that we hope you're going to enjoy. This meeting has 51 CME European credit hours, and there are 126 working hours during these 7 days. And this has been accredited by the European Council for Continuous Medical Education. It's important to know that in this meeting there are 25 international guest speakers, and we hope it's going to be a genuine international experience. I would like to thank the support of the administration, the president of the university, Professor Mahmoud Al-Mitaini, Professor Ashraf Omar, who's the Dean of the Faculty of Medicine, Ain Shams University, Professor Shahira Samir, who is the Vice Dean of Faculty of Medicine, Ain Shams University, for supporting this meeting. As well, I would like to thank all the staff members, coordinators from different departments, and as well Professor Ashraf Badawi and IBIS for organizing this meeting and making this virtual meeting happen. I should not forget also the sponsors of those meetings, because without whom this meeting would not have been held. And I wish you all a very successful and pleasant meeting and pleasant experience with this first virtual Ain Shams University meeting. Thank you.
ستيشن سي بيعيد، ستيشن ايه بيعيد، سي بيعيد. سي دكتور أشرف صباح الخير. دكتور أشرف عبد الموني.
ايوه صباح الخير.
صباح الخير، ازي حضرتك؟ دكتور أشرف بدوي من ايرس فان.
اهلا وسهلا. ازيك دكتور اشرف؟ صح.
الحمد لله. بيه اخبار حضرتك ايه؟
كله بنعمة الحمد لله.
الحمد لله. احنا لسه بقيه الناس ما دخلتش، دكتور محمد خلف، دكتور احمد جمال لسه ما دخلوش معانا.
نستنى شويه؟
ننتظر 5 دقايق ان شاء الله.
اوكي حبيبي، كتر خير، شكرا.
اتفضل يا فندم.
اتفضل.
دكتور احمد جمال.
دكتور اشرف.
ايوه.
دكتور اشرف احنا اوريدي بدأنا. shall we proceed؟
يس اوكي ان شاء الله.
تمام، شكرا جزيلا لحضرتك.
لا اهلا وسهلا بك. I can start.
حضرتك اول محاضره يا دكتور مظبوط؟
ان شاء الله.
طيب هنعمل شير سكرين.
اوكي.
هنفتح البرزنتيشن وبعد كده هنعمل شير سكرين نختار البرزنتيشن.
اوكي. اديني اكسس لو سمحت. محمد سامعني؟
سامع حضرتك يا دكتور.
اديني اكسس لو سمحت.
حضرتك معاك الاكسس، اتفضل.
طيب ثانية. كده تمام؟
تمام يا دكتور.
بسم الله الرحمن الرحيم. الحقيقة احنا في ظروف صعبة بالنسبة للكوفيد. أما الحقيقة بنقدم خالص الشكر للأستاذ دكتور محمود المتيني رئيس الجامعة، الأستاذ دكتور أشرف عمر عميد الكلية الحقيقة، وباقي الزملاء وشركة ايرس الحقيقة المجهود القوي ان احنا نقدم مؤتمر الكلية 41 ونحافظ على الاستمرارية في تقديم هذا المؤتمر. فالحقيقة مجهود مشكور ليهم. أنا أشرف عبد المغني مصطفى، أستاذ الجراحة العامة وجراحات السد طب عين شمس. I'm going to give a brief review of management of breast cancer. All of us know that carcinoma of the breast is one of the major cancer burden all over the world. Second most common cause of cancer-related disease in females. The incidence is increasing, yes, because of mammographic screening and patient awareness and environmental factors. On the other hand, mortality is decreasing because of early detection and better treatment options. History is very important to define a disease. Mastectomized mummies were detected in ancient Egyptians 3,500 years ago, past a very long time. Hippocrates 460 years before century described breast disease as a humoral disease. Cancer is considered systemic. Surgery did not cure because this way a disease involving the entire body, which we call the humoral theory. Years passed and moved to localized theories. 17th century described it as a localized disease, which is potentially curable with surgery. 19th century Halsted era of radical mastectomy, depending on cancer spread anatomically to the local areas and to the axillary lymph node. So lymphatic invasion and direct invasion of surrounding tissue should be eradicated. With the development of with the process of oncological developments, they described elimination of the ovaries will enhance the treatment options in breast cancer. So Piaston and T95 described oophorectomy for treatment of breast cancer. Emil Krapp at T96 described radiotherapy instead of doing open oophorectomy for patient with breast cancer. During that 20th century, the chemotherapy was developed. There are two main influential clinical trials that meet a new concept for treatment of breast cancer, which is National Bowel and Breast Project and the Milan Project. They define that breast conservation and radiotherapy, chemotherapy, and plus or minus hormonal treatment are ideal treatment of patient with breast cancer. This changes the oncological approach, which is a combining surgery, chemotherapy, radiotherapy, biological treatment of breast cancer, and this necessitated the multidisciplinary team to reach tailored approach for each patient. The main stone in breast cancer management is a multidisciplinary meeting consists of breast unit's core personnel, surgeons, radiologists, pathologists, medical oncologists, radiation oncologists, and breast care nurses and radiographers. It is held weekly in the unit. All the imaging and the clinical assessment revised and biopsy results, consensual decision is the outcome. All surgically excised breast cancer cases are discussed regarding decision after treatment. We hope to reach, and we are on our way to one-stop breast cancer, that the patient come for one day and another day for decision. Initial visit takes 2 to 3 hours to establish a diagnosis. Results from the imaging are available at the end of the visit, reducing the anxiety for patient with benign breast lesion. She has no matter to stay or to wait without knowing it is actual disease. Second visit is necessary for biopsy and results and consultation for MT. The modern surgical practice should be less invasive surgery, in contradiction to Hallstedian and Petty theory, more attention to cosmetic outcome, and improved prognosis. Minimally invasive surgery, 1970, breast conservation was advocated, and 1990, sentinel lymph node biopsy was advocated. I'm going to preserve the breast, so I should take care from the arm edema, which occurred during complete axillary resection. Breast conservative surgery was the driving force for oncoplasty, because after breast conservative surgery without oncoplasty, there is a volume reduction, there is some cases of ugly scar, and there is asymmetry of breasts. Axillary surgery, axillary is very important prognostic factor in breast cancer, in addition to the tumor size. So assessment of the axilla is very crucial for the treatment. We have 3 options as axillary lymph node sampling, sentinel lymph node biopsy, or axillary clearance. After the conservation, with its drawback, oncoplasty and reconstructive surgery was advocated in past decade, evolving specialty to overcome the resulting deformity of breast conservation. Preservation of the breast with a cosmetic appearance after oncological resection, what we call oncoplastic resection, or reconstruction after mastectomy, either immediately or delayed. So oncoplasty is defined as resection of the tumor and reconstruction of the defect using plastic surgical technique to obtain a pleasant breast shape to decrease morbidity and psychological stress. The clash of interest between the achieving wide local excision and minimizing the risk of unacceptable local deformity led to the evolution of a range of procedures to reconstruct the resection defect and prevent the need for mastectomy. These procedures allow resection of wide tumor-free margin with the best principles of reconstruction to optimize cosmetic outcome and minimize complications. Defects following local resection of breast cancer is treated by one of two ways: volume displacement and volume replacement. Volume displacement, although technique is limited to the breast, donor side problems are avoided. Ischemia of the dermoglandular pedicle can occur, leading to necrosis, and hence contralateral surgery is usually required to restore symmetry. On the other hand, volume replacement, the technique maintains the original shape and size of the breast, achieve a balanced cosmetic results without need for contralateral surgery. However, they require longer operation time and they can be followed by donor side complications. A volume displacement technique, this is a bi-level classification. Level 1, I guess level 1 is done by most of the breast surgeons in breast conservative surgery, where we don't allow the cavity to be filled by seroma after section of the tumor, and we mobilize the edges of the womb of the breast and they close it in separate closure. Then we close the skin. A level 2 technique is a major volume resection, allow resection for more than 20 to 25% of the breast size, and include more complex procedure derived from the breast reduction technique. I'm going to present some techniques of the oncoplasty. The superior pedicle mammoplasty is very suitable for lower tumors, which are difficult to treat with pleasant appearance of the breast after section. Another technique is the inferior pedicle mammoplasty, also suitable for big breast and tumors located in the upper area of the breast, so we can remove it without the derangement of the shape of the breast. Round lock technique, or what we call donut mastopexy, this is a very important technique because it allows us to remove a tumor juxta-areolar, which were treated before by mastectomy. So we can remove a tumor far away from the edge of the areola, even by 5 to 6 centimeters in a considerable size of the breast, with a very pleasant shape of the breast, and can be corrected on the contralateral side. Batwing technique is a good technique in a voluminous breast and can give an access for a wide area of a tumor starting from the 3 o'clock to 9 o'clock, and you can remove with a pleasant shape like that. Racket incision, or what we call racket mammoplasty, is a simple procedure that can treat upper outer quadrant breast lesions with centralization of the areola and the nipple with a pleasant shape, and it can be corrected contralateral breast. GA mammoplasty, sometimes you have tumors in lower outer quadrant, and GA mammoplasty is a very suitable technique for such tumors. Griszotti technique, this the central tumors in the past were treated by mastectomy, but recently by the Griszotti technique we can remove central tumor by central quadrantectomy. An island of the inferior skin can replace the areola with the towing and nipple formation. After that will solve the problem. Then we move to volume replacement technique. Volume replacement technique by silicone implants and tissue expander. They have advantages and disadvantages. The advantage of a volume replacement technique by silicone: lower initial cost. Technical cases, no special equipment are required. No additional scar or donor site morbidity. Shorter operative time and recovery compared with autologous tissue construction. On the other hand, it is liable for capsular contracture, implant rupture, infection, and asymmetry. It can be done one stage immediate reconstruction with the implant, or 2 stages with tissue expander, which allow for good symmetrization of the both breast. Examples of tissue replacement the mycutaneous latissimus dorsi flap. Standards arc of rotation of the latissimus dorsi mycutaneous flap is based on the thoracodorsal neurovascular bundle. It is a potential autologous reconstruction, soft tissue coverage, which used tissue expander and implant, large diameter pedicle, thoracodorsal artery and veins, minimal donor site morbidity. Disadvantaged high seroma rate, formation up to 79%, may require tissue expander and implant for increasing the breast projection and to volume, resume the volume of the breast. We hope in the prospect in the coming last 25 years, many large trials have led to better outcome. And we should be indulgent for these researches. And we have junior staff and even senior staff indulgent in these researches in the last 5 years. But we need researches in genetic for breast cancer risk reducing, surgery and the prevention, and we need to emphasize the role of stem cell in DCIS. Thank you. Thank you. Was clear? Dr. Ahmed Kamal, Dr. Khalaf, you have audience? I'm waiting for questions.
دكتور صباح الخير.
صباح الخير.
إن شاء الله دكتور أحمد جمال إحنا بنتواصل معاه وخلال دقايق هيكون معانا لايف.
طيب اوكي. Presentation was clear? Hello?
Sorry doctor, I didn't hear you.
The presentation was clear?
Yes, was clear enough. Thank you.
Okay, thank you very much.
دكتور احمد استاذن حضرتك نعمل كونكت للمايك. هنعمل كونكت اوديو. دكتور احمد، في تحت على اليمين بوتون عليه رسمه مايك او عليه رسمه هيدسيت. استاذن حضرتك هندوس عليه هيدينا اوبشن نكونكت اوديو.
ايه الاخبار يا شباب؟ تواصلتوا مع الدكتور احمد؟
بنتواصل معاه دكتور احمد معانا في الباناليست.
هو كان عنده تكنيكال ايرور انك تعملوا شير، عملتوا له؟
احنا تواصلنا معاه وهو معانا بالفعل حاليا از باناليست، بس هو بنحاول نعمل كونكت اوديو من عنده.
طيب ماشي.
دكتور احمد استاذن حضرتك لو سامعني، في بوتون تحت على الشمال عليه علامه هيدسيت او عليه علامه مايك، هندوس عليه ونعمل كونكت اوديو فروم كمبيوتر.
ايوه.
بص احمد، المفروض دلوقتي انا المفروض تسمعوني ولا ايه؟ حد سامعني؟
ايوه يا احمد انا سامع.
تمام، انا كده جاهز.
صباح الخير.
صباح النور يا
انت
فندم.
جاهز؟
جاهز.
طب يلا ابدأ بقى.
السلام عليكم.
ده انت التوب بتاعك مهم جدا.
ماشي. ثانية واحدة، شير سكرين. السلام عليكم. السكرين باينة كده عشان أنا مش واضح عندي، أنا باين ولا مش باين؟
لا السكرين مش باين يا احمد.
الشير سكرين مش باينة؟
صباح الخير يا دكتور، معاك ندى من ايرس مانجمنت. حضرتك ممكن تدوس على الباتن الأخضر اللي تحت شير سكرين.
كده السكرين باينة؟
بالظبط كده.
ايوه يا احمد.
ممكن تعمل البرزنتيشن فول سكرين؟
أنا فول سكرين برزنتيشن ناو.
تمام، ثانك يو دكتور.
السلام عليكم، صباح الخير. هي كده السكرين باينة والدنيا واضحة. ابتدي. ألو؟
ايوه يا احمد ابدأ، السكرين واضح.
أوكي. أنا هتكلم النهاردة إن شاء الله على عين شمس experience in extreme oncoplasty. My session will be a natural continuation of Dr. Ashraf Abdelmohni session. Dr. Abdelmohni give brief procedure, give brief history about breast cancers and management, and he reached to oncoplasty. Now I am going to talk about extreme oncoplasty. First, I would like to declare that there is no conflict of interest with any organization or institute. I will give a brief history for mastectomy as a procedure. Of course, we all know that Hallstatt, who invented this operation in 1894, he operated about 50 cases in Johns Hopkins Hospital. What's radical mastectomy? It is excision of the whole breast, the whole pectoralis major, and level 1 and 2 and 3 of axilla, which resulted to a severe mutilation to the patient. As it's very obvious from the picture we are seeing now, that the chest wall are very apparent, and the patient tend to bend her shoulder in order to hide the extent of mutation. After that, Patty invented modified radical mastectomy. Actually, it is just a modification from the radical mastectomy. He leaves the pectoralis major muscle and removes the fascia. When comparing recurrence, it was found that there is no difference in survival rate at 85% in 5 years between radical mastectomy and less extensive breast surgery. What I want to declare, what I want to focus about, that modified radical mastectomy doesn't different from radical mastectomy, although we leave the whole pectoralis major. Going to late 1970s and early 80s, a prospective randomized trial confirmed survival equivalency for breast conservation when compared to mastectomy. Now we are jumping to a more conservative surgery. We leave the whole breast and we just excise the tumor, and the survival was equal, with higher, of course, local recurrence rate in breast conservative surgery. Another trial, prospective randomized trial in 2013, reported that recurrence rate less than 1.5% at 5 years for patient randomized to excise plus standard whole breast radiation. The local recurrence decrease with adding whole breast radiation. Now, in the early of the 20th century, we perform radical mastectomy, removing the whole breast, removing the whole pectoralis major, level 1 and 2 axilla, going to conservative breast surgery, and we have a huge trial in 2013 said that the local recurrence is less than 1.5%. When breast conservation is performed for patients with larger tumor, it requires, of course, larger resection margin. We want to receive at least 1 cm resection margin, which result to a poor cosmetic result and mutilation also the breast. We go from radical mastectomy to conservative breast surgery to enhance the cosmetic outcome, to improve the cosmetic outcome. But we found with excision of larger breast tumor plus safety margin, the cosmetic outcome is still very poor in such patient. Now we go for extreme oncoplasty. What's extreme oncoplasty? It is a breast conserving operation using oncoplastic techniques in patients who in most physician opinion require mastectomy. There is generally large, greater than 5 cm multifocal or multicentric tumor. They may be locally advanced. Many have positive lymph node. Most of these patients will require radiation. So we go for extreme oncoplasty to improve cosmetic outcomes. According to oncological perspective, we remove the whole tumor with safety margin. In addition, we improve the cosmetic outcomes. For this study done by Sylvester, I want to focus about this point, that the local recurrence, the comparison between extreme oncoplasty and standard conservative breast surgery was non-specific, meaning that the extreme oncoplasty has the same local recurrence rate with traditional conservative breast surgery. In Ain Shams University, here is our experience. Of course, we work in collaboration with the multidisciplinary team formed from surgeons, oncologists, radiologists, pathologists, and we all perform the whole panel for cancer in order to decide which patient will go for mastectomy, for breast conservation, for neoadjuvant chemotherapy, And we perform neoadjuvant chemotherapy, of course, in some patients to reduce this metastasis, select individualized therapy for non-responders, and improve surgical care. In Ain Shams, we put a criteria for selection for patients with extreme oncoplasty. First, T2 less than 5 cm in small breast. And we go for T3 tumors more than 5 cm, not responding to neoadjuvant chemotherapy in larger breast size. I mean, cup D and double D. We go for extreme oncoplasty in multicentric. Diffuse malignant microcalcification affect a quadrant. Patient refusing mastectomy. We go for all these patients and we perform extreme oncoplasty. Here, I'm just focusing about this patient, and this patient perform level 1 oncoplasty. Okay, this patient has upper, outer, and upper inner tumor. Actually, they are impalpable tumors in 2 separate quadrants. By clockwise, one it's at 2 o'clock and the other is in 10 o'clock. And they are marked by wire. We just excise the 2 tumors together and we perform local flap to close the breast. Now, the breast size is actually the same size, symmetry with the other one. And here's the post-operative picture for the patient. Another patient, this patient has large tumor size, retroareolar tumor, 5 × 4 cm infiltrating the areola. It shows actually microcalcification going to the nipple. So we need to excise the central part of the breast. We need to excise the nipple and areola. We go for extreme oncoplasty and we excise the whole central part of the breast with nipple and areola, with the neck complex. And we use this part of the skin and we advance it in the site of the nipple areola and we construct the breast. Here is the picture post-operative by about 5 days, and we still see the Rejuvac here. The breast, of course, decreases in size, and there is artificial nipple and areola of the patient. Here is the patient is satisfied by the outcome. And as a part of Egyptian, they don't like to touch the normal breast size. Here in such patient, we only reduce the size of the affected breast. This particular patient come after she finished the radiotherapy and ask for contralateral symmetralization. Till now, the social background to most of Egyptian patients in our institute refuse to touch the contralateral side of the breast. Going for another patient, she has 6 cm invasive ductal carcinoma mass at 6 o'clock. And her breast is also huge. She went to other institutes and most of them decide for her mastectomy. We go for bilateral breast reduction with removing of tumor with superior medial technique in the right aspect of the breast. And here is the excised part of the breast. And I won't focus here about the limit of resection we perform in such a patient. This patient has 6 cm tumors, and we remove 16 × 14 × 3 cm part of her breast. And the mass actually is 3.5 × 3.5 and × 2 cm. So we attain a huge safety margin in such a patient. And here, her post-operative outcome, immediately post-operative, and about 1 month after post-operative. Patient was very satisfied by her new breast size. The mass was excised with huge safety margin. Going to another patient, this patient has multicentric invasive lobar carcinoma. Actually, she attended our clinic with retracted nipple, as it's very obvious from the picture here. And we take a biopsy, we found that she has invasive lobar carcinoma. We go further for MRI and we found 2 other impalpable lesions in 2 other quadrants in the breast. One juxta-areolar, and there is another one away at about 5 o'clock in the lower outer part of the breast. We see him go for bilateral reduction for this patient. removing the central part of the breast. I call this operation Immovac Grisozzi, and we perform a patch, and the patient is very satisfied by her new breast size, excising the whole tumor, the whole tumors, the whole cancers, the multicentric, with attaining safety margin. Another patient who have upper outer quadrant 10 times 17 mass. Actually, this patient is not a malignancy. She has phylloid, as I remember. Okay, and here is the phylloid, and we reduce her breast size by round block technique, and the cosmetic outcome of the breast was very fine in such a patient. And here is her post-operative outcome. Another patient who have two breast masses, invasive duct carcinoma, one of them showing affection of the skin. So we have upper inner mass with skin dimple and upper outer mass not affecting the skin. Most of centers inform the patient that she requires mastectomy. This patient receives 3 cycles of neoadjuvant chemotherapy with no response on the mass. So this patient go under the category of non-responder to neoadjuvant chemotherapy. So we go for here is the mass 5x4 mass, very close to the skin. Actually, it performs skin dimple, and another mass about 2x2 cm away from the skin. What we perform to this skin, to this patient, we perform an LD flap. We take the LD muscle with the skin, and we tellurize the skin of the back in just a patch as we remove the skin of the breast at the site of the mass, at the site of skin dimple. So we remove the skin dimple, including the mass, we remove the whole tumor, and we put as a LD flap. The LD flap not to reconstruct the whole breast. Actually, it is hemimastectomy, and we perform hemi breast reconstruction. And here is the outcome. The patient, the 32 years old patient, still have post breast. The symmetry between post breast is very nice, and the patient is very satisfied by the outcome. And here, just about 2 weeks from the operation or 1 week from the post-operative period, her breast looks fine. The patient is satisfied. Here's 15 days post-operative for the same patient. Another patient with invasive ductal carcinoma, she has two masses, one juxta-allular and the other mass is upper inner quadrant here. And we go for this patient also for what's called modified round block technique. And what's modified, what's modified round block techniques? Round block is performing two concentric circles, and we remove the skin between the concentric circles. And we go for juxta-allular masses to excite them. But here we perform tunnel. We remove the two masses in one block, this mass and the other mass. We remove the whole two masses in one block just from the outer circle of the round block technique. So we go for modified round block technique, and here is the immediate post-operative outcome for the patient. The patient breast size doesn't affect, and here is also obvious if you concentrate in the picture that there is a mild skin dimple, as we cannot feel this area because it was juxtasternum. But after a while, after 3 weeks from post-operation, the dimple decreased in size, and her shape of breast was very fine. Another patient was 4 to 5 o'clock, 5x4 cm invasive duct carcinoma. Also, this patient will perform for her superior mid-pedicle oncoplasty, and his hair photo post-operative, one by 1 week and the other by about 1 month for the patient. Upper pole, 6x7 cm invasive duct carcinoma. All these patients were asked to perform modified radical mastectomy outside our institute, and we changed the decision into extreme oncoplasty. And here is the outcome of post-operative result for this patient. Another 42 years old patient with invasive duct carcinoma received 6 cycles of neoadjuvant chemotherapy, and the response was very minimal in this patient. She has upper pole breast cancer, and we perform inferior pedicle mammoplasty bilaterally, and here is her photo immediate post-operative. I want to concentrate in most of the operation about something, the extent of excision. We remove 14 times 10 times 5 centimeters from the breast, 14 centi, and we still have the good cosmetic outcomes. So we are not depending on, or we are not still holding that 5 centi. We more than 5 centi, more than T3, we go for mastectomy. Now we have another option that even with T3 masses, even with huge masses, we still have the option of extreme oncoplasty. And here is the patient about 1 month post-operative. Here is another patient, and as we see here, we have a skin affection in the lateral part of the breast, upper outer, and we remove the whole tumor with this part of the skin, and we go for extreme oncoplasty with skin patch. And here is the patient picture after just 3 weeks from the operation. Another patient with multifocal retroarea invasive ductal carcinoma T2N1 and T2N0. We remove the whole tumor as we see the site, the extent of excision. Here is the tumor, here is the excision. And you perform for her modified Griszotti, and also we contrast neutralization. The cosmetic outcome was very nice, and the patient was satisfied by the presence of her 2 breasts. At last, this patient was a little bit tricky. This patient has invasive ductal carcinoma, luminal B, received 6 cycles of new adjuvant chemotherapy, and the mass disappeared clinically. But after performing MRI in such patient, we found fragmentation of the mass. And the fragment part of the mass was extending from 2 o'clock to 5 o'clock. The whole lateral part of her breast was affected by fragmented part of the malignancy. So we have to excise or perform hemimastectomy for the whole lateral part of her breast. For this patient, we go also for extreme oncoplasty, and we perform lateral hemimastectomy, and we go for mini LD flap. From this incision, we dissect the latissimus dorsi and rotate it, and we put it in the lateral aspect of the mass. Here is the latissimus dorsi coming from her back, from the same semilunar incision done to the lateral aspect of the breast, without excising any part from any, without doing any incision in the back. We get the muscle and we put it in the lateral aspect of the breast. And here is the lateral aspect of the breast in comparison to the scalpel. And here is the wire inserted in the middle of fragmented mass. And here is her post-operative outcome. And here is just about 7 days or 10 days from post-operative outcome. Take-home message: we start by Hallstatt from radical mastectomy with severe mutilation, going to Patty with modified radical mastectomy with less mutilation, going to Vernozzi, who perform conservative breast surgery, and we end with Servetian, who go for extreme oncoplasty. And thank you.
Thank you, Dr. Ahmed. Actually, it's very nice presentation. والحقيقة هو ده يصدق فيك الشاعر اللي هو بيقول السيف أصدق أنباء من الكتب. والحقيقة يا أحمد اللي أنت بتعمله ده نتاج سنوات كثيرة من الكفاح من أساتذتنا، نذكرهم بالخير: دكتور عبد المجيد الشناوي الله يرحمه، دكتور رضا مصطفى، دكتور عبد التواب، دكتور فطين عنوس، وريسنتي الدكتور أسامة الأطرش، دكتور سامي عبد الرحمن، واحنا مع بعض كزمايل حقيقة.
أشرف عبد المغني يا فندم.
سامعني يا أحمد؟
وبقول والدكتور أشرف يا فندم،
ربنا يخليك.
مجهود أشرف والمساندة بتاعته في الاسم عندنا طبعا.
الحقيقة ده جيف أواي فور إن الناس تعمل اكستريم أنكوبلاستي. أنا عايز بس تو امفسايز 2 بوينتس، إن إحنا وأنت طبعا عارف ما بنعملش اكستريم أنكوبلاستي إلا العيال اللي واخدين نيو أدجفنت وما عندهمش ريسبونس أو there is no good response أو moderate response. وبالتالي ما بنعملش ماسس كبيرة on front surgery، دايما بياخدوا نيو أدجفنت في الواحد عندنا. ده بيشجعنا يا احمد متهيألي كده ان احنا نعمل ورك شوب، واحنا عندنا عمليات كويسه ونقدر نعمل لايف ترانسميشن ونستخدم برضو زوم بنفس الطريقه، هيبقى كويس يبقى برودكاستد. انا عايز اسالك سؤال بقى، الحقيقه انت في معظم الحالات اللي انت عامل فيها اكستريم اونكوبلاستي كان البريست سايز كبير. لو انا مالتي سنتريك والبريست سايز صغير، ايه الاوبشن الثاني غير انك تعمل اكستريم اونكوبلاستي؟
انا في اخر حاله كان الكاب سايز بتاع البريست بتاعها سي يعتبر صغير، واي جو فور ميني ال دي فلاب partial mastectomy with mini LD flap to fill the gap، او go for skin sparing mastectomy او neck sparing mastectomy.
What should you prefer, skin sparing or mini LD flap, or according to the site and size of the breast, size of the tumor and size of the breast؟
بحط في دماغي كذا اعتبار، تمام. لو لقيت ان انا ممكن اجيبها بميني ال دي فلاب بسيب البيشنت بعملها بميني ال دي فلاب. دايما بحط في دماغي اللي ممكن يجي لي لوكال ريكارنس وممكن احتاج بعد كده اعمل السكين سبيرنج ماستكتومي. ثاني حاجه برضه في بوينت بنخلي بالنا منها في مصر شويه مختلفه عن بره، اللي هي الفاينانشال، لان السكين سبيرنج ماستكتومي از ليتل بيت اكسبنسيف في مصر عشان الامبلانت بالظبط.
تمام، يعني انت بيبقى باكد اب باي امبلانت بتخليه سكند ستيج
فور سكند ستيج.
جود. انت طبعا الحقيقه الصور جميله وشغلك كويس جدا، وطبعا بياخد وقت كتير في الباثولوجي.
طبعا
يعني طبعا. ممكن حاله زي دي تقفل لسته كامله.
ساعتين ممكن طبعا.
طيب كويس، حلو. عايزين برضو ان احنا طبعا كل ما بيبقى في عندنا بيلدينج اب اكسبيرينس، سواء بالنسبه للسيرجن الليرنينج كيرف بتحسن، وبالنسبه للباثولوجيست اي جيس انه التايم ده كان بريديوس، ونقدر نعمل حالات اكتر في اليوم ان شاء الله.
ان شاء الله.
شكرا يا دكتور احمد، كتر خيرك على البرزنتيشن الجميل
جدا، على الفرصه الجميله دي.
شكرا، ربنا يحفظك. شكرا. I guess Dr. Muhammad Khalaf, who can't reach, might be for communication conflict.
Dr. Ahmed Ali, can you please proceed?
صباح الخير.
صباح النور يا فندم.
الصوت بتاعي مسموع كويس؟
تمام يا دكتور، اتفضل.
طيب هو لسه دكتور محمد ندى ودكتور كريم؟
أنا معاك يا أحمد، أنا معاك. يا فندم.
ماشي. طيب ابدا انا البرزنتيشن بتاعتي ولا حضرتك؟
ابدا. اتفضل يا دكتور احمد، اتفضل.
ماشي يا فندم.
هو اولا بدايه احنا بنحب بس نرحب بالبارتيسيبنت معانا في الفورث انيوال عين شمس جنرال سيرجري كونفرنس، و تو بريزنت طبعا السبيكرز اللي معانا دكتور احمد علي ودكتور كريم كامل ومحمد ندى اللي هو انا معاكم في ديفرنت توكس. مش هناخد وقت، احنا عايزين نبقى ستيك للتايم شويه، فاتفضل يا دكتور احمد.
صباح الخير. أنا هتكلم على موضوع الريكتال برولابس. طبعا موضوع يعني ما هواش بيتشاف كتير. الا عن طريق الكولوبروكتولوجيست اكتر ناس بتشوفه، لكن في الجنرال براكتس حتى خصوصا بالنسبه للجنرال سيرجنز ممكن ما يكونوش بيقابلوه قوي، او ممكن يكونوا بيقابلوه لكن ما بيعرفوش يشخصوه او يتعرفوا ان ده ريكتال برولابس يستدعي مانجمنت عن طريق سبيشاليزد كولوبروكتولوجيست. ان شاء الله البرزنتيشن بتاعتي مش هتبقى طويله علشان زي ما الدكتور محمد قال لان يبقى ستيك تو تايم. هنجو فورورد على طول. ريكتال برولابس او ممكن برضو بيقال عليها ريكتال بروسيدنشيا، هي طبعا معناها ان بيحصل برولابس في partial thickness او full thickness of the rectal wall through the anal orifice. وبالتالي من خلال التعريف ده نقدر نقول ان هي ليها 3 types. اول تايب اللي هو complete rectal prolapse معناها full thickness protrusion of the whole rectal wall through the anal orifice. او النوع الثاني اللي هو partial rectal prolapse معناها mucosal prolapse. والنوع الثالث اللي هو الاقل بتاعهم اللي هو internal intussusception، وده اصعبهم في التشخيص. احنا هنركز على البارشال والكومبليت ريكتال برولابس في التوك بتاعنا. اول حاجه نتكلم على البارشال ريكتال برولابس في الايتيولوجي بتاعها. هي طبعا ممكن تحصل في التشيلدرن وممكن تحصل في الادلتس. الايتيولوجي بتاعها في التشيلدرن مينلي بيبقى الكوزز اوف بيرسيستنت ستريننج، يعني طفل عنده كرونيك كاف، كرونيك كونستيبيشن، او حتى كرونيك دايريا، عنده مال نيوتريشن، الكونكتيف تيشو بتاعته ضعيفه، فممكن يحصل له برولابس اوف بارشال ريكتال and the anal wall thickness through the anal orifice. بالنسبه للادلتس البارشال ريكتال برولابس ده ممكن يبقى associated مع، هو غالبا ما بيكون كده، associated مع other conditions زي الفورث ديجري هيمورويدز، او لو patient عنده anal polyp، او ممكن في بعض الاحيان بعد بعض الانال اوبريشنز تحصل mucosal prolapse. ده المنظر بتاع patient عنده partial rectal prolapse. واضح ان هي يعني ده patient كان عنده third to fourth degree piles، فبيبقى عنده mucosal prolapse بالمنظر ده. ساعات بتبقى circumferential واخده كل الانال كمان. طب الكلينيكال بيكتشر بتاعتها بتبقى ايه؟ هي دايفرس، يعني ممكن يبقى البيشنت بيشتكي من ان يقول ان في protrusion of tissue خارج من الانس بتاعته especially during defecation. ممكن يبتدي الموضوع يخش في complications زي bleeding، زي itching، زي discharge، زي ان هي تبتدي تدخله في infection، او تبقى painful في حاله لو حصل فيها strangulation. في الاكستريم كيسز ممكن يحصل incontinence كمان بسبب. طيب البيشنتس دول بيتشخصوا ازاي؟ بيتشخصوا مينلي عن طريق الاكزامينيشن، يعني مفيش انفستيجيشن معينه هنقدر ان احنا نعملها عشان تقول ان البيشنت ده عنده بارشال ريكتال برولابس. اهم حاجه الاكزامينيشن زي معظم الانال كونديشنز. طيب العلاج بتاع البارشال ريكتال برولابس ده بيبقى فيه عندنا تو تايبس، في كونزرفاتيف وفي سيرجيكال. بالنسبه للكونزرفاتيف تريتمنت في الاطفال غالبا في حالات البارشال ريكتال برولابس بنمشيهم كونزرفاتيف تريتمنت عن طريق ان احنا لو في اندرلاين كوز كان ستريننج، اذا كان كاف، بنعالجها ونحسن النيوتريشن، ومع الوقت البيشنت ده بيتحسن جدا وممكن يختفي من عنده الريكتال برولابس ده. اما في الادلتس برضه نفس الكلام، الكونزرفاتيف تريتمنت بتبقى عباره عن ان انا احسن الدايتري فايبرز كويس جدا، ممكن ادي ستول سوفتنرز معاهم، اخلي البيشنت ده يافويد تماما الستريننج مع الستول، وممكن يستعمل جليسرين سبوزيتوري علشان يساعد في الريكتال ايفاكيويشن. ده الكونزرفاتيف ميجرز بتاعت البيشنتس اللي هم عندهم بارشال ريكتال برولابس بس ما هواش سيجنيفيكانت قوي وما هواش عامل له سيمتومز عنيفه. اما بالنسبه للبيشنتس بقى اللي بيشتكوا من سيمتومز بيرزيستنت وفيلد معاهم الكونزرفتيف تريتمنت، يبقى يفضل ان احنا نعالج لهم البارشال ريكتال برولابس ده عن طريق سيرجري. انواع السيرجري البارشال ريكتال برولابس فيه ممكن نعمل انجكشن بحاجات اللي هي سكليروزنج ايجنتس، او الباندنج في البيشنتس اللي عندهم بايلز فيرست وسكند ديجري، او في الحالات بقى اللي هي بيبقى عندهم فعلا بارشال ريكتال برولابس محترم، دول يفضل ان احنا نعمل لهم ستيبلد هيمورايدكتومي عن طريق الدباسه اللي هي PPH اللي صورتها موجوده في البرزنتيشن دي، ودي الحقيقه بتجيب نتائج هايله في الحالات اللي زي كده. بالنسبه للكومبليت ريكتال برولابس فهي الايتيولوجي بتاعتها غالبا ما بتيجي الكومبليت ريكتال برولابس ده في بيشنتس عندهم كرونيك ستريننج، برضه 50% من الحالات بتبقى كده. الموست كومن ايج جروب اللي بيجي فيه الريكتال برولابس كومبليتلي هو الاولد فيميل بيشنتس اللي هم اتعرضوا للمالتي باريتي، خصوصا كان عندهم نورمال فاجينال ديليفري، وبيبقى طبعا مع الايدج بيبقى عندهم ويكنس في البلفيك فلور ماسلز وبيحصل لهم بلفيك فلور ديسفانكشن، فبالتالي بيعانوا من كومبليت ريكتال برولابس. برضه في بعض البيشنتس اللي بيبقى عندهم نيورولوجيكال ديس اوردرز زي كرونيك لور باك بين اند باك سيرجريز كودا اكواينا، البيشنتس دول بيبقى عندهم ساعات كومبليت ريكتال برولابس. والبيشنتس اللي عندهم سيستيك فايبروزس برضه وجد ان في جزء منهم بيبقى عندهم كومبليت ريكتال برولابس. الباثولوجيكال اناتومي طبعا في الحالات اللي زي كده بتبقى عباره عن mainly weakness في pelvic floor muscles، وبالتالي بيحصل distortion في النورمال اناتومي والنورمال سسبنشن اوف ذا ريكتم، فبيؤدي ان الريكتم ده بينزل ويخرج جزء منه بفول ثيكنس من الانال اوريفيس اثناء الديفيكيشن. طيب الابيديميولوجي زي ما قلنا ان الاولد فيميل بيشنتس هم دول اكتر بيشنتس عرضه ان يحصل لهم كومبليت ريكتال برولابس، كذلك بعض السايكاتريك بيشنتس، وبتحصل في بعض الحالات في البيشنتس اللي هم اليونج تشيلدرن والانفانتس اللي عندهم مال نيوتريشن ومال نارشت، لان السسبنشن بتاع البلفيك فلور بيبقى ضعيف جدا فيه. ان ايجيبت بقى في عندنا سبيشال برزنتيشن كده، ان يعني معظم الحالات اللي احنا بنشوفها الحقيقه مش اولد فيميلز، بيبقوا يونج ادلت ميلز. كانوا بيقولوا قبل كده انه بسبب البلهارزيز، لكن طبعا دلوقتي البلهارزيز شبه اختفى من عندنا، ولازال فعلا البيشنتس اللي بيجوا لنا حتى في المرداش يعني از سبيشاليزد يونت بيبقى معظمهم يونج ادلت ميلز، مش مفهوم بالظبط ايه السبب. السيمتومز بتاعتها برضو بتبقى بروجريسيف، بتتراوح من برولابس الى ميوكوزال ديسشارج الى ايتشنج، وقد تتطور الى بعض الكومبليكيشنز هنقولها. ده منظر الكومبليت ريكتال برولابس، وزي ما هو واضح كده بيبقى فيه كونسنتريك رينجز اللي هي بتاعه السيركولار ماسل فايبرز الموجوده في الريكتال وول. ده بيؤكد ان هي كومبليت، يعني كل الثيكنس بتاع الريكتوم خارج من الانس. التشخيص بتاعه بيبقى ازاي؟ مينلي عن طريق الفيزيكال اكزامينيشن، بنشوف البروتروجن اوف ذا ريكتال ميكوزا، بنؤكد كمان ان هي اذا كانت بارشال ثيكنس ولا كومبليت ثيكنس. نقدر كمان نشوف السفنكتر، لقينا السفنكتر تون بتاعتهم اخبارها ايه، وبرده لو في البيشنت ده لو عمل لو عمل ستريننج وطلع الريكتال برولابس بالكامل، ممكن اشوف لو هو عنده سوليتري ريكتال ألسر، ودي بتبقى ساعات اسوشيتد مع بيشنتس اللي بيبقى عندهم كومبليت ريكتال برولابس او اوبستراكتد ديفيكيشن. طبعا في بعض الانفستيجيشنز بتتعمل، بس التشخيص مينلي عن طريق كلينيكال دايجنوز. ممكن تعمل انفستيجيشنز كتير جدا من ضمنها حتى MRI بروكتوجرافي، لكن ما يطلعش ان هو عنده كومبليت ريكتال برولابس. مجرد بس ان انت تخلي البيشنت يسكوات او تقول له صورها لي حتى في الحمام، هيصورها وتشوف المنظر بتاع كومبليت ريكتال برولابس، تعرف ان هو ده التشخيص بتاعه. طبعا ليها ديفرنشال دايجنوزز زي الهيمورويدز، انترسبشن، بروكتايتس اند ريكتال بوليبس. طب الكومبليكيشنز بتاعتها، في كومبليكيشنز طبعا مختلفه بتتراوح من ulceration، bleeding، infection، strangulation and up to انها يحصل لها رابشر. طبعا المنظر ده احنا ما شفناهوش قبل كده، انما هو موجود في الليترشر. طب الانفستيجيشن زي ما قلنا بالنسبه للتشيلدرن، يعني يفضل ان احنا ننفستيجيت لو في اندرلاين كوز يكون مسبب الموضوع بتاع الريكتال برولابس ده، من ضمنهم السيستيك فايبروزز. في الحاله دي يفضل ان احنا نعمل التست عشان نشخصها، او لو عنده انفكشنز مسببه ستريننج او مسببه كف نشخصها. بالنسبه بقى للادلتس، يفضل للبيشنتس اللي عندهم اوريدي دوكيومنتد خلاص ريكتال برولابس نعمل لهم كولونوسكوبي، او على الاقل ريجيد بروكتوسكوبي، بروكتوسيجمويدوسكوبي، علشان نشوف لو في اي اسوشيتد باثولوجي موجوده مع الريكتال برولابس ده ما تبقاش ميسد مني. ممكن يبقى في بوليبس، ممكن يبقى في مالجنسي هيدن مع بيشنت عنده ريكتال برولابس، او يكون في سوليتري ريكتال ألسر. في الحالات دي يهمني قوي ان انا اعمل كولونوسكوبي او ريجيد بروكتوسكوبي. طب العلاج بتاع الكومبليت ريكتال برولابس في جنرال كونسيدريشنز كده. اول حاجه كومبليت ريكتال برولابس في الادلتس لو هو فعلا موجود وايفيدنت وتشخص، يفضل ان هو يتعالج سيرجيكالي، لان هو مش هيفيل معاه كل الكونزرفتيف ميجرز. الكونزرفتيف ميجرز بقى دي تستخدم في البيشنتس اللي عندهم انترنال برولابس او انترنال انترسبشن او التشيلدرن، دول ممكن نستعمل معاهم كونزرفتيف ميجرز. مفيش جولد ستاندرد اوبريشن، كل بيشنت لازم المانجمنت بتاعه يبقى تailored على حسب الكونديشن بتاعته. والقاعده العامه ان في كل الحالات دي يفضل ان احنا نعمل باول بريباريشن قبل العمليه علشان نقلل الريسك اوف انفكشن. انواع الاوبريشنز طبعا هم 2 abdominal procedures و perineal procedures. ان جنرال كده الابدومينال بروسيجرز هي ليها لور ريكورنس ريت، لكن طبعا الموربيديتي بتاعتها بتبقى اعلى، سبيشالي في حته النيرف انجري اللي هي السمباثيتك والباراسمباثيتك بلكسس اللي موجوده في البلفس، ممكن يحصل فيها انجري، ودي طبعا ممكن تسبب لنا موربيديتي عنيفه اذا كانت في الديفيكيشن في السكشوال لايف، سكشوال بيرفورمانس، وكذلك في اليورينيشن. اما بالنسبه للبرينيال بروسيجرز فهي ليها هاي ريكورنس ريت، لكن طبعا الموربيديتي بتاعتها اقل. عشان كده بنقول ان كل بيشنت لازم نتيلر البروسيجر المناسبه ليه على حسب حالته. سريعا كده الابدومينال بروسيجرز طبعا عندنا اشهر عمليه اللي هي الريكتوبيكسي، ممكن تتعمل ابدومين، ممكن تتعمل اوبن، لاباروسكوبيك، روبوتيك. وطبعا المينيمالي انفيزيف تكنيكس دلوقتي اللي هي اللاباروسكوبي والروبوتكس هي اللي بقت واخده الابر هاند في الابدومينال بروسيجرز. طبعا الموربيديتي بتاعتها قلت كتير بعد ما ابتدينا نشتغل باللاباروسكوبي، وروبوتكس طبعا اللي هي موجوده اكتر في الغرب. الريكتوبيكسي دي في عندنا منها كذا نوع، ممكن تبقى سوتشر ريكتوبيكسي اللي هي اكتر عمليه احنا بنعملها عندنا في اليونت، هي دي الادوبتد تكنيك في الابدومينال بروسيجر عشان الموربيديتي بتاعتها من ناحيه الانفكشن اقل. او ان احنا نعمل ميش ريكتوبيكسي، ودي مشهوره اكتر في اوروبا. الميش ريكتوبيكسي كانوا بيعملوها بوستيريور قبل كده، دلوقتي جولد ستاندرد كميش ريكتوبيكسي هي الانتيريور ميش ريكتوبيكسي. في عمليه ثانيه مشهوره اكتر في امريكا اللي هي ريسكشن ريكتوبيكسي، ودي بتتعمل في حالات لما البيشنتس يكون عندهم ريدندنت سيجمويد كولون اسوشيتد مع كومبليت ريكتال برولابس، بيتعمل ليميتد سيجمويدكتومي ومعاها ريكتال ريكتوبيكسي. برضه من ضمن التكنيكس اللي ممكن تتعمل الموصوفه اللي هي انتي ريسكشن دي في حالات يعني اكستريم شويه. بالنسبه للبرينيال بروسيجرز بقى عندنا طبعا الستاندرد بتاعتهم اللي هي ديلورمز بروسيجر، اللي هي معناها ميوكوزال سليف ريسكشن. دي بتشال جزء من الميوكوزا والسب ميوكوزا بتاعه الريكتم والانال كانال اب تو يعني سيجمنت محترمه حوالي 5 ل 10 سم، وبعدين بيتعمل بلايكيشن للوول اللي هو ريدندنت ده علشان يتكشكش على بعضه ويخش جوه الانس ما يخرجش تاني. في برضه عمليه ثانيه اسمها التيماير بيرينيال ريكتوسيجمويدكتومي، ودي في البيشنتس اللي عندهم كومبليت ريكتال برولابس وسيجمويد كولون خارج من يعني خارج من خلال الريكتال برولابس ده، فدي بتعمل لها ريكتوسيجمويدكتومي من خلال الانس. عمليه ما بتتشافش كتير بس هي موصوفه نتائجها كويسه. طبعا في عمليه ثالثه اسمها انال انسيركلمنت اللي هي ديرش اوبريشن، ودي مشهوره اكتر في الاطفال، اللي هي بنعمل زي بنصغر يعني حجم الانال اوريفيس علشان ما يخرجش الريكتم منها عن طريق ثريد. والعمليه اللي بقت تتعمل برضو دلوقتي كثيرا هي الستار ستيبلد ترانس انال ريكتال ريسكشن، ودي بتتعمل في البيشنتس اللي عندهم ريدندنت ميكوزا لكن ما عندهمش سيفير ديسنت او ما عندهمش سيجمويد خارج في الريكتال برولابس، هي مينلي ريكتال، فدول ممكن نعمل لهم عمليه اللي هي ستار او عمليه اسمها ترانس ستار كمان اللي هي دي المشهوره اكتر للريكتال برولابس، بتتعمل عن طريق دباسات كونتور وبتعمل ريسكشن للجزء ريدندنت من الريكتم ده، نتائجها برضو مبشره. الكومبليكيشنز اوف سيرجري طبعا في الجنرال اوبراتيف والبوست اوبراتيف كومبليكيشنز العاديه، لكن طبعا الحاجات الشهيره بالنسبه للبرينيال بروسيجرز اكتر ممكن يحصل انفكشن وبليدنج. بالنسبه طبعا للابدومينال بروسيجرز ان يحصل باول انجري او انستوماتيك ليك لو انا عملت ريسكشن ريكتوبيكسي، او اكتر حاجه بنخاف منها هي زي ما قلنا الهايبوجاستريك نيرف افكشن اللي ممكن ياثر على البلادر او سيكشوال فانكشن او يعمل كمان اوتلت اوبستراكشن. عشان كده الابدومينال بروسيجرز محتاجه اكسبيرينس في البروسيجر دي علشان نقلل موضوع النيرف انجري ده جدا. بروجنوزز وريكورنس بتاعتهم جنرالي البروجنوز بتاعتهم بتبقى كويسه جدا. 90% من التشيلدرن اب تو 3 years نيد اونلي كونزرفاتيف ميجرز زي ما قلنا. في بعض الحالات اللي هم البيشنتس الادلتس اللي عندهم كومبليت ريكتال برولابس ووصلتهم لانكونتيننس، ساعات الكونتيننس بتاعتهم ده بتبقى افكتد بعد العمليه، انما مع السكسس ومع الوقت بتتحسن الكونتيننس جدا. ريكورنس ريت بتتراوح في الابدومينال بروسيجرز 3 ل 4%، بتزيد شويه في الورمز بروسيجر او في البرينيال بروسيجرز up to 26%. Thank you.
شكرا دكتور احمد، محاضره جميله. وفي اي ديسكشن على المحاضره؟ طب نقدر نبتدي. دكتور كريم موجود؟ دكتور كريم؟
لا دكتور كريم مش موجود، فممكن دكتور محمد ندى حضرتك تبدأ المحاضرة.
اوكي يا فندم. ثانية واحدة. أولا سعيد إن أنا متواجد النهاردة في المؤتمر الكلية وفي الفورث annual conference للجنرال سيرجري ديبارتمنت جامعة عين شمس. محاضرتنا النهاردة عن how to choose the ideal method to repair rectovaginal fistula. At the beginning, rectovaginal fistula is a very distressing disease and with profound negative psychological and social impacts. It is defined as an abnormal epithelialized communication between the rectal and the vaginal cavities, causing passage of flatus or stool from the rectum to the vagina with recurrent vaginal infections. As we know, the most common cause is obstetric sphincter injury, obstetric injury during vaginal delivery, which represents about 30 to 80% of all iatrogenic rectovaginal fistulas. However, it could be manifested after vaginal, anal, and perineal surgeries. It may complicate introduction of foreign bodies. Obstetric rectovaginal fistulas may be accompanied with obstetric sphincter injury, as the mechanism of trauma can initiate both. Can initiate in our rectovaginal fistula or sphincter injury للanal canal. It is classified according to the etiology, location, size, and complexity. The scheme based on location, classifying fistulas as being low, mid, or high, depending on the fistula's opening into the rectum. A low fistulas, which opens near the dentate line. Fistulas are considered small if the diameter of the opening is less than 0.5 centimeter, medium from 0.5 to 2.5 centimeter, large لو هي أكتر من 2.5 centimeter. Keeping in mind that there is no definitive track in this special version of fistulas. It is a communication between the vagina, the posterior vaginal wall, and the anterior rectal wall. وبالتالي ما فيش proper track في الفيستولز في rectovaginal fistulas. Rectovaginal fistulas are considered complex if they are large, high, recurrent, or caused by another causes like inflammatory bowel disease. Repair of rectovaginal fistulas is a challenge even to expert surgeons due to the high failure rate, which may be attributed to the communication between a positive pressure septic cavity, which is the rectum, and a negative pressure cavity, the vagina, with very thin layers separating both cavities, hence easily infected. Different techniques of repair were described, varying from a primary repair, flaps, and even using meshes, with different approaches, either local, like transvaginal, perineal, transanal, or abdominal approach for proximal fistulas that couldn't be accessed from the previous approaches. Upper fistulas, or higher fistulas, we couldn't reach these fistulas from the perineum or the vagina or the anus, so it needs an abdominal approaches. It's important to know that proctectomy could be the only line of definitive treatment in fewer situations. This represents different types of repair: local repair, like vaginal approach, rectal approach, perineal approach, flap advancement, mucosal partial thickness internal sphincter, anterior rectal wall, sphincter preserving transabdominal repair with interposition of tissues like layer closure without power resection or power resection, pull-through technique, low anterior resection. From this, we find that there is multiple types, different types of repair. ما فيش حاجة ideal إن أنا أقول rectovaginal fistula we repaired with this technique, which is the best technique. Colostomy or not? The need for diverting colostomy for rectovaginal fistula is a matter of debate among surgeons. But theoretically, it may improve the outcome by preventing soiling and consequent infection, especially in the early post-operative period. But on the other hand, doing a stoma adds a more distressing situation to the patient. This necessitates careful selection of patient that would have improved outcome of rectovaginal fistula repair by adding a diverting stoma. وبالتالي مش كل عيان هعمل stoma. The proper selection of the patient who's in need for colostomy is important. Marsh's flap has been described for rectovaginal fistula repair. It is a very simple pedicle flap procedure with a success rate ranging from 60 to 100%, in which the pulpocavernosus muscle with the surrounding fibroadipose tissue of the labia majora are interposed at the rectovaginal space through a subcutaneous tunnel, preserving the postero-external vascular pedicle. The choice for best technique must be tailored for each patient individually, with special concern to the underlying pathology, proximity of the fistula, the complexity of the fistula, surgeon preference, and familiarity to the proposed technique of repair, especially for the local repair approaches, is strongly improves the outcome of the repair. وبالتالي, if I'm doing a type of repair repetitively and I'm perfect in doing it, مهم جدا أنا بستيك للتكنيك اللي أنا بحقق فيه نتائج أحسن. Up to 50% of obstetric rectovaginal fistulas could be resolved spontaneously with proper antibiotics, drainage, removal of any foreign bodies. وبالتالي ما تستعجلش في الريبير. wait على البيشنت اللي عندها rectovaginal fistula up to 3 to 6 months. اوكي، لو ما فيش اي طبعا other complications it could be spontaneously healed لوحدها. Management of IPD fistulas is very challenging and needs aggressive medical control of the disease before offering any type of surgical repair. وده طبعا الرول اوف MDT، ان احنا في العيانين اللي عندهم IPD لازم يبقى في contribution من الجاسترونترولوجيست معانا علشان نشوف الميديكال تريتمنت للعيانين دولت نبتدي امتى. يورك ميسون approach اللي هي البوستيريور approach could be suitable alternative to abdominal approach in higher and mid-rectal fistulas. Sphincter repair should be performed concomitant with operative correction of the rectovaginal fistula whenever fecal incontinence is associated. What we do? طبعا proper drainage plus or minus colostomy, especially in presence of vaginal fecal contamination with severe vaginitis. Local examination under general anesthesia is a very important key for proper management عشان أحدد the level of the fistula. And what I will do, we prefer interposition of March's flap after closure of both rectal and vaginal defects, the low and mid fistulas. Even with failed first trial of repair, the second chance carries a greater success rate. يعني بالتالي ما زعلش قوي في الفيلير في الفيرست ترايل، السكند ترايل السكسس ريت بتاعي افضل من الفيرست ترايل كمان. Enlarged rectal defects, post-anterior resection rectovaginal fistulas and post-irradiation rectovaginal fistulas, proctectomy للأسف طبعا proctectomy with coloanal anastomosis or pull-through technique هو اللي needed للعيانين دولت. واضح في الصورة ديت الاكزامينيشن اندر جي اي، وبحدد الديفكت بتاعي، البروكسيمتي بتاعته فين، الليفل بتاعه فين، والسايز اوف ذا ديفكت. ده perineal dissection in a plane between the sphincter complex and the posterior vaginal wall. هنا الفاجينا ودي الريكتم داون، ودوت البرينيال ووند. الفورسبس باسز من الفاجينا وبيحدد السايز اوف ذا فيشلا coming out in the perineum where the fistula is divided. خلاص هي divided في هذه المنطقة. ده الريكتال سايد اوف ذا فيشلا، واضح انها فيشلا كبيره وحصل تريمنج للادجز بتاعها، عملنا تريمنج عشان نعمل برايمري كلوجر للريكتال وول. دي المارشز فلاب اللي هو الفايبراديبوز تيشو والبالبوكافيرنوزوس ماسل، اتاخدت من الليبيا ماجورا، ادي الانسيجن فور دايسكشن، ليفنج طبعا البيديكال بلاد سبلاي جاي لها من البوسترو اكسترنال اسبكت واوبتيند للبرينيال ووند. هنا اتعمل هنا primary closure للفاجينا وفيشلا and the fistula is trimmed and repaired. الريبير حصل للفيشلا وبقفل البرينيال ووند بسوتشرز. طبعا لما نيجي نسال الريكتم هقفله بايه؟ الريكتم هقفله دبل لاير عن نفسي، بقفل دبل لاير. اول لاير اللي هي الميوكوزا بتبقى فايكل 30 or 20، الماسل بقفلها بي دي اس 30، الفاجينا بتتقفل عادي خالص بفايكريل 20. Thank you.
شكرا دكتور محمد ندى على المحاضرة الجميلة، ومش عارف بقى كريم كامل موجود ولا لا.
دكتور كريم apologized.
طب في اي discussion regarding المحاضرتين؟
طيب انا عندي سؤال دكتور محمد.
اتفضل يا باشا.
الريكتوفاجينال فيستولا من your own personal experience. حضرتك do you go first على طول دلوقتي بمارشس فلاب، ولا بتحاول الاول تريبير without فلاب، يعني بتسيف الفلاب دهيت للفيلير ريتس؟
لا هقول لك يا دكتور احمد، هي طبعا لو حاجه فيري ماينور او حاجه فيري لو يعني في الانال كانال نفسها، لا ممكن اتراي without فلاب. انما ما دام انا في الراكتم لا هعمل فلاب، وبعدين بناخد فلاب ناحيه واحده زي ما انت عارف، يعني بناخد ناحيه وبن بريزيرف الفيلير للناحيه الثانيه، يعني ناخد فلاب من الناحيه الشمال طبعا بنبتدي بيها لان هي على عدلتنا احنا، على عدله ايدينا اليمين، وبنسيب الناحيه الثانيه للفيلير السكند فيلير. لكن من تجربتي مع البرايمري ريبير للاسف رغم ان شكله بيبقى حلو في كثير من الاحيان، انما للاسف بيحصل الفيلير فيه اعلى، وبالتالي لا طبعا بطلت خالص فكره البرايمري ريبير الا لو هي لو فيستلس.
تمام. هي مشكله كمان ان حتى السبيس اللي بنعمل منه ريبير بيبقى فيري سمول وفيري نارو، فحتى لما بتعمل ريبير without interpositioning tissue بيبقى الخيط يعني السوتشر لاين في الفاجينا وفي الانس او في الريكتم على بعض، فالانسنس ريكورنس بيبقى عالي. هي دي المشكله.
عالي جدا. وهو حتى لما اجي اعمل ريبير، يعني انا بفضل حتى الريبير للريكتم دوت ما يتعملش ترانسفيرس، يعني ما تعملش باراليل للبرينيال انسيجن بتاعي، لا يتعمل من بروكسيمال تو ديستال، بالذات في اللارج ديفكتس عشان ما اعملش ناروينج للريكتم. خلي بالك الحته دي هاي بريشر، تحتيها هاي بريشر اريا اللي هي الانال كانال، وبالتالي لو عملت الريبير في الحته ديت ان انا قربت رايت تو ليفت سايد اوف ذا ريكتم اوف ذا ديفكت، هعمل ناروينج في الحته دي، ديسربشن للسوتشرز بتاعي هيبقى بدري، وعندنا حالات حصل فيها يعني مشاكل زي كده يعني. وبالتالي هي فيري ديسابوينتنج يعني بصراحه، يعني ريكتو فاجينال فيستولا عمليه يعني فيها فيلير عالي يعني مش قليل، فالواحد يعني بيبقى حاطط حسابه مع العيان حتى ان خلي بالك في سكند ترايل واحتمال يبقى في ثيرد ترايل، وان يعني بحيث العيان ما يطالبش طلبكش باوتكم هو مش بايدك اصلا. هو انا بس سؤالي ليك بقى يا دكتور احمد ريجاردنج المحاضره بتاعت حضرتك، سامعني يا دكتور احمد؟
سامع.
اوكي. هل انت يعني هل في الباثولوجي نقدر يعني نتكلم مثلا نقول ان الكومبليت برولابس او الاوفرت برولابس اللي طالع لبره دوت هو كان بدايته انترنال برولابس؟
يعني اعتقد ثيوريتيكالي
بس انا ما شفتش عيانين عندهم انترنال برولابس من اللي بيجوا لنا، عارف لو بتوع obstructed defecation وريكتوريكتال انترسبشن يعني يمكن عشان ما شفتش العيان في الوقت دوت يعني، او المانيفستيشنز بتاعته يعني ظهرت لي بدري، يعني ما شفتش فكره ان هو بيبقى اوفرت برولابس.
يعني حضرتك تقصد ان مش شرط انه يحصل لهم برولابس كومبليت. ما هو ده حقيقي، بس هي انا حضرتك بتسالني يعني هل حالات الكومبليت ريكتال برولابس هتبقى غالبا ابتدت بانترنال انترسبشن؟ اعتقد هو طبعا ممكن يكون البيشنت بيشتكي ومحدش عارف يشخصه، لان زي ما حضرتك عارف احنا في مرضى كتير بيجوا وانا مثلا كنت بعمل لعيانين MR بروكتوجرافي واقول له انت هتمشي كونزرفاتيف ومفيش عندك حاجه، وبعدين يقول لي لا اصل في حاجه بتخرج مني، فاقول له روح صورها الاقي كومبليت ريكتال برولابس. يعني حتى في الاكزامينيشن في العياده ما بيبانش
لا خالص لا. وهو فكره ان هو يصورها دي فكره هايله بصراحه اللي انت قلتها دي، ان هو العيان حتى during defecation، اصل حتى الMR هو في ستريننج فيز ما فيهوش ديفيكيتنج فيز، فبالتالي حضرتك فكره ان هو يصورها دي فكره رائعه جدا.
بتبقى بصراحه بتعمل صور زي اللي اتعرضت كده بتبقى جميله
زي اللي اتعرضت دي. طب المش انت بتعمل مش يا دكتور احمد ولا لا؟
لا انا مش بعمل مش خالص صراحه
خالص مش يعني
مش علشان هي وحشه، هي في الليتريتشر هي تعتبر الجولد ستاندرد في اوروبا، بس بالنسبه للسيتويشن عندنا في مصر عشان احنا فعلا كل الحالات اللي انا اشتغلتها تقريبا يونج ادلتس، فانا ما افضلش ان انا اخد مش حاله
صح طبعا. وبعدين هم بيستخدموا بره المش بتاعتنا البرولين العاديه ولا انذر تايب؟
لا برولين.
برولين عادي خالص بتاعتنا.
بس
حتى في
بيقفلوا
الباكسي.
نعم.
حتى في الانتيريور مش.
حتى في الانتيريور مش، بس هم بعد ما بتقفل بعد ما بتعمل الريبير والمش ريكتوبيكسي بيتقفل البريتونيوم عليه. ما بتتسابش اكسبوزد يعني.
انت عارف ان كان في قضيه كبيره جدا على فكره المش ديت في الريكتو فاجينال سبتم؟ فاكرها دي بتاعت
فاكرها طبعا.
قصه كبيره جدا جدا. خلاص الديسبارونيا اللي بتحصل بوست اوبراتيف والكومبليكيشن اوف ذا مش في هذه القصه في السبيس دوت. وانت عارف الانتيريور مش ريكتوبيكسي انت بتسلك بالذات في الفيميلز بقى، لو احنا بنتكلم على فيميلز
بتسلك كله ريكتو فاجينال سبيس
كله. فكان في قضيه كبيره جدا جدا على البرولين مش بالذات.
انا بصراحه من الحالات اللي احنا يعني عندنا عموما واشتغلناها شايف ان الاوت كم بتاع السوتشر ريكتوبيكسي كويس جدا.
صح. انا مش شايف ديفرنس في الريكارنس ما بين المش والسوتشر ريكتوبيكسي.
يعني فعلا حتى بكلم البيشنتس هو مبسوط. ودي حاجه قليله انها تحصل اصلا.
بالظبط. وشايف ان الكومبليكيشن بتاعت حتى لو الريكارنس ريت اوف ذا مش ريكتوبيكسي قليل، انما الماجنتيود اوف ذا كومبليكيشن اوف مش ريكتوبيكسي لما بتحصل لا يستدعي بتاتا ان انا استخدم مش. يعني هي مفيش فيها ريبير. وانس المش اتحطت صعب جدا جدا انها تتشال. جانب الكومبليكيشن بتاعتها مش ملهاش ريبير.
لا دي كومبليكيشن بتبقى ديفاستيتنج.
جدا جدا. المهم انا شكرا ليك يا دكتور احمد.
شكرا لك محاضره جميله، يعني ان شاء الله تتكرر تاني كذا مره.
ان شاء الله يا فندم. وشكل ايريس طبعا، وشكل كليه الطب كلها والقسم الجراحه، ونراكم على خير.
ماشي يا فندم، شكرا جزيلا.
صباح الخير دكتور هشام، معك ندى من ايرس مانجمنت. حضرتك
صباح النور يا ندى، ازيك؟
الحمد لله.
البارتيسيبنتس عارفين يخشوا كلهم ولا في الدكتور خالد كان عنده مشكله؟ دكتور خالد الفقي
اهو احنا بنتابع معاه دلوقتي يا دكتور ومعانا يعني بنكلمه ان هو ازاي يعمل اكسس ويدخل. فحضرتك حابب البرزنتيشن دلوقتي جاهزه؟
مش انا اللي هعمل برزنتيشن، انا باناليست، فاللي هيعملوا برزنتيشن النهارده دكتور هشام ماجد. ممكن هو يبتدي وقبل ما الدكتور خالد يخش. انتوا هتدوا له اللينك عشان المحاضره بتاعته، مش كده؟
اي هو المفروض معانا دلوقتي في البانلست باسم دكتور هشام عبد العال. هو حضرتك سامعنا يا دكتور؟
دكتور هشام المفروض سامعنا دلوقتي اهو.
دكتور هشام احنا مش عارفين نسمع حضرتك.
دكتور هشام افتح المايك من تحت، هتلاقي العلامة اللي تحت، افتح المايك. مش سامعينك.
دكتور هشام هتلاقي تحت على ايد حضرتك الشمال في بutton بتدوس عليه وتدوس على join. طب دكتور ممكن لو ممكن لو حضرتك تشيل الهيدفون، ممكن يكون المشكلة فيها.
يعني
تمام.
طيب اوكي كان سامعين يا دكتور هشام؟
سامعك يا فندم.
طيب ممكن بس حضرتك تعمل شير سكرين للبرزنتيشن بتاع حضرتك.
طيب
هو الاول طبعا احنا بنرحب بجميع الحضور وسعداء بالكونفرنس ان هو الحمد لله نجح ان احنا نعمله السنه دي رغم المشاكل بتاعه البانديميك اللي هو موجود. So I'm actually I'm Professor Hisham Al-Aad, general surgeon and upper GIT surgeon, and I'm welcoming everybody to this session. We are all very glad that the 41st Congress has been held despite the COVID pandemic, and this is a very important step for our Ain Shams University. We didn't miss one of our conferences because of this pandemic. This session is about upper GIT surgery, and the first speaker is Professor Dr. Hisham Magid, and he is going to present to us now something about the updates in the management of achalasia. So please, Dr. Hisham, you can start now.
Dr. Hisham, please proceed with your lecture. دكتور هشام حضرتك سامعني؟
ايوه دكتور هشام انا سامعك. عايزين نعمل شير بقى سكرين. انا
استاذن حضرتك تفتح البرزنتيشن الاول.
افتح البرزنتيشن فتحته.
تمام بقى كده حضرتك هات زوم.
اوكي.
في زرار اخضر تحت اللي هو شير سكرين، حضرتك تدوس عليه.
على نفس البرزنتيشن يا استاذ دكتور احمد؟
لا في الزوم في حضرتك اختار البرزنتيشن من الليست اللي طالعه.
انا دلوقتي فاتح قدامي البرزنتيشن دلوقتي.
حضرتك افتح الزوم بقى تاني.
افتح الزوم تاني. اوكي.
تمام.
ثانية واحدة بس. ايوه.
في زرار اخضر تحت مكتوب عليه شير، ممكن حضرتك تدوس عليه.
مفيش عندي زرار تحت، مفيش شير.
زوم تحت خالص مفيش زرار اخضر.
يا جماعة يا دكتور هشام صباح الخير. دكتور هشام.
ايوه.
هشام there is a problem. لا هشام العقاد there is a problem من السبلاير. يعني دلوقتي بس حالا اشتغل الفيديو عندي. انا بقالي ربع ساعة سامعك انت وهشام بتتكلموا مع بعض وانتم لا سامعيني ولا دلوقتي بس تكوميونيكيت معاك. انتوا سامعيني يا جماعه ولا مش سامعيني؟ الو؟
انا سامعك دكتور خالد. انا سامعك دكتور خالد.
هشام العقاد سامعني؟ مش فاهم حاجه.
احنا سامعين حضرتك يا دكتور هشام العقاد ميوتد، بس احنا سامعين حضرتك وحضرتك تقدر تنيبل الفيديو اي وقت. دكتور
انا جاهز.
شايف الزرار الاخضر تحت في الزوم؟
في شير سكرين اهو.
انا متاكد
فين اشتغل؟ يا جماعه ايه بس فين؟ ليه احنا مش هنعرف نشتغل، لازم نرجع تاني. لا هنعمل شير.
دكتور هشام ممكن حضرتك تقول لي ايه اللي ظاهر عند حضرتك تحت في الزوم؟
مين بيتكلم؟ مين بيتكلم؟ الو؟ ممكن اتكلم انا يا جماعه لو مش عارفين. لا هم طبعا هم مشكله عندهم مش عندنا مشكله.
دكتور هشام مش عارف يشرح البرزنتيشن فهم بيحاولوا يقولوا له اعملوا ازاي.
لو هشام ماجد يعني؟
لا دكتور هشام العقاد.
مش هشام العقاد بيعمل برزنتيشن. ده هشام ماجد بيعمل برزنتيشن.
دكتور خالد انا الزوم عندي مش عايز يفتح. مش عارف حضرتك سامعني؟ انا الزوم عندي الزوم عندي قافل.
عندي
في مشكله عندي.
هشام حضرتك بتستخدم البراوزر ولا الابلكيشن؟
بستخدم الابلكيشن.
ممكن لو سمحت مين معايا؟ مين موجود على الخط دلوقتي؟
حضرتك احمد سيري من ايرس.
احمد تقدر تشغلني انا يا احمد؟ انا دكتور خالد الفقي. جرب كده معايا انا.
حضرتك يا دكتور اللي بتشير من عند حضرتك من زرار شير سكرين زي ما حضرتك عملت من شويه، بس هو دكتور هشام مش لاقي الزرار لسه.
ادي شير سكرين اهو.
تمام بالظبط كده.
أيوة. وانا ريدي وهبتدي معاكم وشوفوا هينفع ولا مش هينفع. اوكي؟
خلاص تمام.
بسم الله الرحمن الرحيم. السلام عليكم. I hope everybody is all right and now we can communicate each other through the Zoom. Can you give me a feedback? Are you hearing me or not?
انا سامعينك يا دكتور خالد. انا سامعك.
وشايف السلايد بتاعتي؟
وشاف السلايد
دكتور هشام العقاد. اوكي انا الكونتينيو بقى مش هو ظاهر دكتور هشام العقاد مش قادر يوصل. احمد ايرس سامعني يا احمد؟ الو؟
انا شايف
We can okay, I'll go on. Today, it's my pleasure to be among my friends and colleagues in the surgical department of Ain Shams University. Actually, I'm going to speak about something which is a bit uncommon, which is the gastrointestinal stromal cell tumor. This tumor is is very uncommon, and its treatment and management have been changed greatly in the last decade. Our lecture will cover the presentation, diagnosis, and management of such uncommon disease. Actually, surgery is the main goal, the main line of treatment, and with the better understanding of the pathophysiology of this tumor, the strategy of treatment has been changed toward the medical side as well. If we go to the pathophysiology, guests are very uncommon. I've told you before, it's just 2% of all GIT tumors and 5% of all soft tissue sarcomas. It's a rare mesenchymal tumor. To understand the treatment and the presentation of these tumors, we have to go back to the history of it. I think all of us, our generation, couldn't recognize the existence of Guest tumor when we are medical students or even a fresh graduate. And all these tumors were named wrongly as a leiomyoma or leiomyosarcoma, and sometimes we could not differentiate between the benign and malignant tumors, and here we are calling them, it's a smooth muscle tumor, leaving to the biological behavior of the tumors to differentiate between the benign and malignant sites. With the advances of electron microscopy and with the evolution of the immunohistochemistry, the name of Guest has subsequently introduced, as most of the stromal cell tumors have quite features of typical smooth muscles. With the evolution of immunohistochemistry, the discovery of the cluster of differentiation 34 expression in 70% of Guest tumors, as well as the tyrosine kinase KIT CD117, marked the revolution in the diagnosis and treatment of Guests. Hence, the mesenchymal tumors of the GIT has been differentiated into Guests, schwannomas, and smooth muscle tumors. Guests and the interstitial cells of Cajal express the receptor kinase, tyrosine kinase KIT CD117, and here we are now referring that Guests arises from the Cajal cells. The typical picture or macroscopic picture is spindle and epithelioid or mixed, and it is important to the pathologist to put in his consideration that CD117 also present in other tumors like seminomas and small cell tumors of the lung and thyroid cancer and melanoma. The incidence and malignant potentiality, Guests are underdiagnosed and its morphological spectrum is wider than what is recognized. The estimated annual incidence of Guests around 15 per million a year, and it's recorded in the UK 900 new cases. Actually, I collected the number of Guests resected in the upper GI unit and among our fellows and colleagues in the surgical department in the last 18 months in Ain Shams University. The actual number was around 34 cases. The site of the tumor and the symptoms at the diagnosis and the organ of origin and the number of the mitotic figures are the most important factors when we are assessing the prognosis. The disease-specific survival after complete resection of the primary Guest is based on the tumor size. Those tumors less than 2 centimeters have negligible mitotic activity and considered very low risk. In this diagram, it's clear now that the size of the tumor and the number of the mitotic count per 50 per high power field will determine the risk of the tumor. Less than 2 centimeters, as you see here. Less than 2 centimeters is a very low risk. Between 2 to 5 centimeters could be low risk or intermediate risk, depending on the mitotic figures. Those with mitotic figure less than 5 will be at very low risk. Mitotic figures more than 10 or more than 10 centimeters will be at high risk. The demographic and anatomical distribution, no marked sex difference. The age distributed at the BUNI model. Most of the guests are either in the stomach or the small intestine, very rarely to be in the esophagus or the rectum or the omentum. Approximately 10 to 30% of guests are overtly malignant and presentation, and the principal site of metastasis are the liver and the peritoneal cavity. Spread of the lymph node is very rare, and this will tell you that radical resection is not a target or a strategy for the treatment, but actually en-bloc resection with safety margin is all what the surgeon needs when he go for surgery. The clinical presentation, the problem in the diagnosis of the symptom of guests are most of them are non-specific, and the symptom will depend on the size and the location of the lesion. Small guests are 2 centimeters or less are usually asymptomatic, and there's some dilemma about the management of small tumors. Most guests arrive in the stomach and the small intestine, and infrequently in the esophagus and mesentery, as I've told you previously. In the stomach, 70% of the cases, the small bowel 20 to 30%, esophagus and mesentery 10%, omentum, colon, and rectum are quite rare. The clinical picture and presentation and diagnosis is always challenging, and the symptoms are usually non-specific, I've told you, especially in small tumor less than 10 centimeters, and mucous membrane in most of these cases are intact, and endoscopic biopsy is very difficult. This is a case of a gastric tumor in the third part of the duodenum. I remember this patient presented with a typical, he has gallstones, but when I hear quite well his symptom, the symptoms are not biliary colic. So we do CT, and CT showed us this tumor, which is a tumor in the third part of the duodenum. Here is the tumor. And this is another case of gastric tumor in the esophagus, and it's treated by esophagectomy. And here is the multiple guests arising from the hypopharynx and actually creeping down to the mid-esophagus, and was diagnosed wrongly as a malignancy, and taking a biopsy. The endoscopic biopsy ended by perforation of the esophagus, and we went for urgent esophagectomy, and the patient went well after that. A huge guest arising from the tail of the pancreas. Here is it. As I told you earlier, the abdominal pain may be non-specific, 20 to 50% of cases, bleeding 50% of cases, and gastrointestinal obstruction in 10 to 30%, asymptomatic in 20 cases. In many cases, the mucous membrane is normal, and here is the biopsy is very difficult, and the GIT bleeding is present in approximately 50% of cases. Here is about an ulcerating gastric tumor in the duodenum, in the antrum of the stomach, and ended by severe bleeding and treated by resection later on. How to investigate a patient of guests? Here is the challenge to diagnose. You have to depend on the clinical picture. How do you get data from the clinical data of the patient and the investigation? And the investigations here, endoscopic ultrasound is the most predictive tool to differentiate between benign and malignant lesion preoperatively. In the signs of malignancy, which be shown in the ultrasound or the CT or MRI, all of them are equal, which means irregular margins, tumor more than 3 centimeters with heterogeneous echo pattern. If fine needle aspiration is added to the endoscopic ultrasound, it has a diagnostic accuracy up to 78%. CT and MRI, a typical large mass arising from the GIT tract with mucosal ulceration and central necrosis and cavitation and heterogeneous enhancement after IV contrast indicates a malignant tumor. MRI may provide an excellent soft tissue contrast resolution in multiplanar imaging, and this will give you a better strategy for surgery to define the extension of resection you are going to do. Here is a huge, as you see here, a huge tumor in the in the tail of the pancreas and encroaching on the spleen, the stomach. This is the huge tumor I showed you before. Everybody is working in the field of gastric surgery has to put this in consideration. The central placed tumor in a male patient under the age of 40 should have an alpha-fetoprotein and beta human chorionic gonadotrophin level to exclude non-seminomatous germ tumors. While patients with tumors in tumor in the left or the right upper quadrant, he should have an endocrine assessment to exclude large functioning adrenal tumor. What is GESS syndrome? It's a very presentation of patient of GESS to have association of three uncommon neoplasms: GESS functioning extra-adrenal paraganglionoma and pulmonary chondromas. These are, in contrast to the GESS tumor, 85% of those patients are females. Laparoscopy may be considered in the staging of large lesions to exclude peritoneal metastasis, but exploratory laparotomy is usually required to decide whether a large primary tumor is technically resectable or not. The treatment and prognosis of GESS tumor. The target of GESS management is to achieve RO resection, as complete excision offers a good chance of cure. A wide local resection with macroscopic removal of the entire tumor is recommended. The surgeon should aim to preserve function, but not on the expense of RO resection. Extended lymphadenectomy, as I've told you earlier, is not normally recommended and not required. Oesophageectomy is the standard procedure for esophageal GESS, and submucosal excision are much more likely to be put for leiomyomas and which needs inoculation. As I told you, gastric section could be partial gastrectomy, subtotal, total, wedge, laparoscopic sleeve gastrectomy, and we have to put direct invasion to the surrounding structures occur in 10 to 15% of cases, and surgery in such cases should include en-bloc resection. The extension of resection is dictated by the size of the tumor and its location and its invasion to the surrounding structure. The debate of resecting incidentally discovered tumor less than 2 centimeters, actually there is some debate. Some authorities and some people in UK and States advocate just follow-up, especially if the MRI or the endoscopic ultrasound finding don't show any high-risk features. In larger series where retrospective analysis looking for the rate of growth of small tumor, they found that 13% with low-risk features on endoscopy proceed to a point where they were resected. So the challenge here is to operate or not, to follow up the patient or to operate in him. But I think, to the best of my knowledge or to my point of view, to follow up the patient is not a very safe procedure for patient who will have a malignancy or a malignant transformation by 15% if we follow him up. The National Comprehensive Cancer Network in UK guideline for the management of gastric GESS less than 2 centimeters without high-risk feature on endoscopic ultrasound includes surveillance endoscopy every 6 to 11 months. This is their point of view. To my point of view, or for our culture, I think this is not a good option for our patient. Let us speak shortly about imatinib. Imatinib is a imatinib methylase is a receptor tyrosine kinase inhibitor. Actually, this is a revolution in the management of GESS, as I told you earlier. As this is after the advancement of happened in the immunohistochemistry, this drug inhibit tyrosine kinase. It's take it orally, establishing for the following up. It's established before for the treatment of chronic myeloid leukemia, and it is used here for guest tumor post-operatively for a year or 2 or 3. It depends on the protocol applied for the patient, and they found over 50% patients with metastasis or resectable guest will survive more than 5 years if they were treated of imatinib. And the follow-up after 5 years, when we give the imatinib as an adjuvant treatment, give the better survival and the better morbidity outcome after its use. In a trial led by American College of Surgeons Oncology Group, oral imatinib for 12 months following resection in patients with high-risk GIST was shown to improve recurrence rate-free survival and increase overall survival when compared with historical control. Dose of imatinib could be for 1, 2, 3 years, but actually most of our oncologists here in Egypt give the patient imatinib for 3 years. Imatinib as a new adjuvant therapy as well. It's a trial led by the Radiation Therapy Oncology Group revealed that the imatinib is well tolerated as a new adjuvant setting, and in locally advanced tumor more than 5 centimeters where imatinib is given for 8 weeks preoperatively in a dose 600 milligrams per day, followed by additional post-operative day for 2 years. Response rate after 8 weeks of preoperative imatinib as determined by the response evaluation criteria for solid tumors were similar between group A and B, 4 to 7% partial response, 83% to 90% of stable disease, and 4 to 5% progressive disease. The 2-year progression-free survival rate were 83 and 77 in both groups. Resectable or metastatic disease, the role of imatinib for resectable and metastatic disease, although it is not yet settled, but actually it's helped a lot to, in many cases, in many series, to turn irresectable cases to resectable cases and to preserve the function in many other cases, like patients with rectosigmoid or rectal guests. You can save the sphincter here, and patient with gastroesophageal junction, you can save the patient from esophageal resection after using them. Thank you so much.
To Professor Dr. Khalid Al-Fiqi for this very nice presentation. Very informative, actually. And any questions from the audience for Professor Khalid? I have few questions, but from the audience first. Any questions?
Professor Hisham, waiting for questions.
All right. What do you think is the appropriate safety margin for the resection of GIST? If we are having a GIST near the esophagus, for example, how much should we take from the esophagus so that we might even avoid a thoracotomy for an anastomosis and so forth?
I think just 1 centimeter is more than enough, Professor Hisham, as there's no lymphatic infiltration and no lymphatic spread. It depends about how do you feel about your case and how would you will feel better technically on getting your reconstruction.
All right. Now, what about if there is a recurrence? Do we have to carry on with the imatinib only? Or
Yes.
Is it better to get inside once more and try to remove once more the tumor?
It depends. You know, there are now different generation of tyrosine kinase inhibitor, more advanced than imatinib, but I don't put it in our in my presentation to minimize the time. But actually, when if the patient didn't get imatinib, give him imatinib preoperatively, and if this fails, go to the second generation of tyrosine kinase inhibitor, and to follow the patient strictly for after 2 or 3 months to see how does this tumor respond to the tyrosine kinase inhibitor. If he didn't respond, go for surgery. But if it regresses, leave the tumor to regress on medical therapy, the neoadjuvant chemotherapy or neoadjuvant therapy, and then defer the surgery as a second step.
Okay, thank you very much. If there are no other questions, we might proceed with the next speaker, Professor Dr. Hisham Magid. Thank you, Professor Khalid.
Welcome to the professor.
All right, now Professor Hisham Magid will update us about the management of achalasia. We can see your screen, but we do not hear your voice. Professor Hisham Abdullah.
Dr. Hisham, can you please unmute yourself?
كده سامعني كده؟ الو دكتور هشام سامعني؟
Yes, we can hear you, Dr. Hisham.
طيب ممكن البرزنتيشن يبقى واضحه عندكم؟
هنحتاج حضرتك to be full screen.
اوكي فول سكرين اوكي تمام. Okay, today I'm going to discuss the update management of achalasia of the esophagus. Achalasia esophagus is a motility disorder, as you know, characterized by absence of peristalsis and failure of relaxation of the lower esophageal sphincter. This causes obstruction at the level of the esophagogastric junction. What's the etiology of achalasia? As you know, we have primary achalasia, we have secondary achalasia. Primary achalasia, the cause of primary achalasia is unknown. But this may be caused by a damage of nerve cells of involuntary nervous system within the muscle layer of the esophagus. They are attacked by the patient all immune system and slowly degenerate for a reason that are currently not understood. However, we have another category of achalasia called secondary achalasia. This is a small proportion of achalasia. Some such as esophageal cancer at the lower end of the esophagus can mimic the picture of achalasia. Also, other diseases like Shake's disease. What's the histopathology of achalasia? The histopathological examination of achalasia show a decrease of the neuron in the meninteric plexus. Also, there is a decrease in the nitric oxide producing cells. These contribute to the failure of relaxation of lower esophageal sphincter, and there is a relative sparing of the cholinergic neuron, which is responsible for maintaining of the lower esophageal tone. The loss of inhibitory neurons lead to an increase in the resting tone of the lower esophageal sphincter. So what are the main signs and symptoms of the achalasia? As you know, the main signs of this dysphagia is difficult to swallowing solid or fluid. Also, there's a regurgitation of undigested food, chest pain, weight loss, coughing when lying horizontal position, or aspiration. This is the main symptom of achalasia, mainly dysphagia to solid and liquid, difficulty in belching, to less extent chest pain and regurgitation and heartburn. Any patient with symptomatic features of achalasia should undergo 3 main categories of investigation: radiological investigation, manometric investigation, and endoscopy. Here's a classic picture, X-ray picture of the patient of achalasia. We can see now there is the dilatation of the mediastinum. There is an air and fluid level from retained food. There is an absence of the fundic air bubble. This is a barium swallow in patient of achalasia, where there is a huge dilatation of the esophagus. There is smooth texture lower down, what we call parrot beak appearance. This is a barium swallow of patient with vigorous achalasia, in which there is multiple non-peristaltic muscular contraction of the dilated esophagus. Second, very important investigation in any patient of achalasia, we should do manometry. Of course, the manometry should be done in all patients to confirm the diagnosis. All patients with achalasia characterized by three features. That is elevated lower esophageal sphincter pressure more than 45 millimeter mercury, incomplete relaxation of lower esophageal sphincter, and aperistalsis. Also, manometric studies is a characteristic feature in manometry in which we find usually the resting intraesophageal pressure is slightly higher than the intragastric pressure, which is in the normal condition. This is the reverse is the correct. By manometric study, we can classify the achalasia into three main categories. Type 1 achalasia, which is characterized by complete absence of esophageal peristalsis. Type 2, which is characterized by pan-esophageal pressurization. Type 3 is characterized by spastic contraction of the esophagus. Of course, these three types affect the prognosis and treatment outcome according to the type of achalasia. Here we have the endoscopy. All patients with achalasia should be undergo endoscopy, as endoscopy is very important because we should some patients with lower esophageal carcinoma can mimic the picture of achalasia. So endoscopy evaluation is very important to exclude malignancy at the esophagogastric junction that can mimic primary achalasia clinically and radiologically and manometrically. Endoscopy in achalasia, we can, of course, we can see a dilated esophagus. We can see retained food inside. Usually the esophageal mucosa is normal unless there's an inflammation from retained food. We can find inflammation and ulceration of the esophageal wall. Sometimes whitish plaque of the wall can be seen from candida infection. Now we are shifting to the treatment option of the achalasia. We have three main categories: either medical treatment, or endoscopic treatment, or surgical management. Medical treatment in the form of nitrate, calcium channel blocker, endoscopic injection of botulinum toxin. Endoscopic management like balloon dilatation or per-oral endoscopic myotomy. Surgical management like oral or laparoscopic myotomy. Pharmacotherapy of the achalasia, of course, this therapy is brief action with common side effect. And we reserve this type of treatment to only patient who is unfit for surgery or unwilling to do other procedures. Now we are going to the endoscopic treatment. The first endoscopic treatment is pneumatic dilatation. We use a several sized polyethylene balloon in this type of medications. We use greater size polyethylene balloon, which are intraluminally dilated, that lead to the disruption of inner circular muscle layer of lower esophageal sphincter by air pressure. Initially, we use starting by balloon number 3, with subsequent symptomatic and objective evaluation after 4 to 6 weeks. For patients who continue to remain symptomatic, dilatation with next size dilator can be employed. This serial pneumatic dilatation approach has shown to have an excellent success rate. In some series, it can reach up to 93% symptomatic relief after serial pneumatic dilatation. But unfortunately, this type of treatment usually give poor results in male patients less than 45 years because of the thicker lower esophageal sphincter muscle. And for this group of patients, usually we prefer to start by other mode of treatment option, like surgical myotomy or per-oral endoscopic myotomy. So pneumatic dilatation carry a significant risk. What's the complication of after pneumatic dilatation? The more serious complication is the esophageal perforation, and it's reported to be about the incidence rate about 2% in best hand. So we should always be available. The surgical backup should be always available, and also the patient should be informed that we can shift him to the operation room if perforation occur. Other complications include gastroesophageal reflux disease. The incidence of gastroesophageal reflux disease post-pneumatic dilatation is ranging from 15 to 35% of patients. This should be treated by long-term proton pump inhibitor to avoid the occurrence of peptic stricture. Also, prolonged post-dilatation chest pain can occur after the pneumatic dilatation, intramural hematoma, traumatic diverticuli. This is also the complications after pneumatic dilatation. Second, endoscopic treatment of achalasia. We have the per-oral endoscopic myotomy. This per-oral endoscopic myotomy is a form of a natural orifice transluminal endoscopic surgery that is completing by creating a submucosal tunnel at the lower esophagus to reach the inner circular muscle bundle of the esophagus to perform myotomy. Usually, we prefer to do a selective myotomy. Selective myotomy means we do myotomy for the inner circular muscle and sparing the outer longitudinal muscle layer of the esophagus. Also, the field of per-oral endoscopic myotomy is extended to be now there is a gastric per-oral myotomy in which we can do myotomy for pyloric sphincter to treat gastroparesis. Also, the endoscopic rectal endoscopic myotomy to treat adult Hirschsprung disease. Per-oral endoscopic myotomy was first introduced by Ortega in 1980. This is the first person who developed this procedure, but the Ortega limited his myotomy in the lower esophageal part, in the lower esophageal rosette only, and he made his study on 17 patients, and he reported an excellent study, excellent results after per-oral endoscopic myotomy compared to the surgical myotomy. The current form of per-oral endoscopic myotomy was developed by Professor Inui in Japan in 2008. He advocates the use of the submucosal tunnel to reach the inner circular muscle bundle of the lower esophageal sphincter to perform a myotomy. So he can do a long myotomy. Following the initial publication, Professor Inui make his initial trial on 43 patients with lower esophageal achalasia. He also reports an excellent result with a success rate more than 95% of cases. Okay, to summarize the technique of the per-oral endoscopic myotomy, we have we have 4 steps for per-oral endoscopic myotomy. At first, the mucosal incision. Second step is creation of submucosal tunnel. Third is performing myotomy. Fourth step is closure of the mucosal tear. So by using of forward viewing scope with distal cap, with transparent distal cap and triangular or rounded tip knife, we can use this knife to dissect the submucosal layer, also to cut the inner circular muscle layers. We can use also the coagulating grasper for hemostasis. First step, as I told before, we do mucosal incision. By using, first we inject a mixture of methylene blue and epinephrine in some mucosal space, starting about 12 to 16 centimeters from cardioesophageal junction, to raise the submucosal pleb. Then we do a mucosal incision. The incision is done longitudinally with careful dissection of submucosal fiber around the linear incision. Then after that, we forward put the scope inside the submucosal spaces to create the submucosal tunnel. So after creation of submucosal wound, usually we do this mucosal wound as a 2 o'clock position. In recurrent cases after previous per-oral endoscopic myotomy, we can start at 5 o'clock position. We can do this mucosal tear at 5 o'clock position. The next step after mucosal tear, as I told, we create a submucosal tunnel. After creation of the entry site, the scope is advanced within the submucosa while preserving the integrity of the mucosa. It's very important to spare the mucosa as as the mucosa is the only barrier now between the esophageal lumen and the mediastinum. So it's very important to keep the integrity of the mucosa. We dissect the submucosal tunnel very carefully to avoid the injury of cut and injury of the mucosa. After that, we proceed for creation of some mucosal tunnel, and any bleeding vessel should be coagulated by a hemostatic forceps. How we can identify the gastroesophageal junction? We identify the gastroesophageal junction by finding the narrow space. If the gastroesophageal junction is identified by narrowing of submucosal spaces and by there is a resistance. We find a resistance when we advancing the scope. We find a resistance. This means that we are reaching the gastroesophageal sphincter. Also, the appearance of omega shape or spiral shaped blood vessels is another indicator for we are reaching the gastroesophageal junction. So after the gastroesophageal junction is identified, the scope is advanced 2 to 3 centimeters beyond this junction, and for creation of long myotomy. The third step after creation of submucosal tunnel, we start to do myotomy. Of course, we prefer to do a selective myotomy of the inner circular muscle fiber, but sometimes selective myotomy is very difficult. As we know, there is an adherent between the inner and outer longitudinal muscle fiber, especially as the cardioesophageal junction. Also, the outer longitudinal muscle fiber is very thin muscle layer, so it's very difficult. Some endoscopists advocate the use of total myotomy instead of full thickness myotomy instead of selective myotomy, as it is less time consuming. شايف البرزنتيشن. اوكي. Okay. Fourth step after finishing the myotomy, we do closure of the mucosal incision. We should after finishing of creation of some mucosal tunnel and creation of the myotomy, should inspect the space very well, and if there is any bleeding blood vessel should be coagulated. If there is any mucosal tear, should be closed. After that, we start to close the original mucosal incision by endoscopic clip, starting from the lower end of the wound. Okay. Post-operative care. After the procedure, a gastrografin swallow study with fluoroscopy should be obtained to avoid to be sure there is no any leakage after the procedure. Solid diet should be started 2 days after the procedure, and regular diet from 10 to 14 days. Injection antibiotic for 3 days, and then oral antibiotic for the 7 days. Proton pump inhibitor should be continued for 15 days. What is the contraindications for oral endoscopic myotomy? The contraindication of endoscopic myotomy is, of course, severe esophagitis, patient with bleeding disorders, patient with liver cirrhosis. All this is a contraindication to perform this procedure. large esophageal diverticulum is considered a relative contraindication for the peroral endoscopic myotomy. So what's the complication after the procedure? We have many adverse effects, but in experienced hand, the peroral endoscopic myotomy is safe procedure. The most dangerous, or most severe complication is mucosal tear. That's why we insist to close any mucosal defect or any mucosal tear early as possible to prevent the occurrence of mediastinitis. So the complication of is mucosal tear and should be addressed early and closed early. Bleeding, second complications, and this is why we should, after creation of some mucosal tunnel, we should inspect the space very well, and if there is any bleeding vessels, should be coagulated by our hemostatic procedure. The most common complication after the peroral endoscopic myotomy is GERD. And the incidence rate of GERD after the procedure is ranging from 20 to 57%. So some endoscopists advocate the TIF procedure to treat this GERD. TIF, it is transoral incisionless fundoplication to decrease the incidence of GERD both after the procedure. Also, other complications, other procedure to decrease the GERD incidence is to do selective myotomy and sparing the outer longitudinal muscle layer. Also, some endoscopists do myotomy for only 1 centimeter below the gastroesophageal junction instead of 3 centimeters. All this procedure to decrease the incidence of GERD post the procedure. Pneumoperitoneum is another complication for the procedure, but small pneumoperitoneum occur in 50% of cases and usually left without any treatment. But intention pneumoperitoneum should be decompressed by a wide bore cannula. Pneumothorax also can occur and usually left to resolve spontaneously. But in case of tension, pneumothorax should be drained by intercostal tube. Now we are shifting to surgical myotomy. After we finish the endoscopic procedure to treat achalasia, we are now shifting to surgical myotomy. Surgical myotomy can be done either through an oral, through an open procedure, or laparoscopic. Open either transabdominal or transthoracic. Laparoscopic myotomy with fundoplication. As you know, the era now is for laparoscopic myotomy. We start the myotomy at the gastroesophageal junction, and we extend our myotomy approximately up to 5 to 8 centimeters by dividing the cervical muscle layer and distally to 1 to 1.5 centimeters by dividing the oblique muscle layers of the stomach.
دكتور هشام, careful with the time, huh?
طيب اوكي انا خلاص قربت اخلص دكتور هشام. So okay, as we know, we divide the muscle layer and we make 2 flap, and after that we do an anterior fundoplication or a door fundoplication. But notice that we start by suturing the anterior layer of the stomach to the left side of the myotomy. And after that, we suturing the anterior stomach to the right side of the myotomy. In the dotted line, we can see the extension of our myotomy. Of course, the function outcome of myotomy is strongly related to the preoperative staging of the disease on the esophagogram. All patients with stage 1 and 2 of the disease have excellent result, whereas less satisfactory or bad result occur in patient stage 3 and 4. Stage 1 is when the diameter, if the diameter of the esophagus is less than 40 millimeters. Stage 2, diameter from 40 to 60 millimeters. Stage 3, the diameter greater than 60 millimeters. Stage 4, any diameter of the esophagus with sigmoid configuration of the distal esophagus. In failed surgical in the failure after surgical procedure, طبعا the last option is do oesophagoectomy, but oesophagoectomy of course it has a high rate of morbidity and mortality. Okay. Here is a comparison between the per-oral endoscopic myotomy and laparoscopic hilar myotomy. Of course, in the per-oral endoscopic myotomy, there is no scarring. In the laparoscopic hilar myotomy, there is a scarring. In the per-oral endoscopic myotomy, we can do selective inner bundle myotomy.
كمان قدامنا وقت قليل او رضا لسه وراه.
طيب انا خلصت بيه خلاص. يعني هو this is a comparison between the two procedure. Here بس the post-operative GERD is 15% in the laparoscopic hilar cardiomyotomy, and in the per-oral endoscopic myotomy the post-operative GERD is 20-30%. Okay, thank you.
Thank you very much, Professor Dr. Hisham. I think we will have to proceed على طول with Professor Dr. Reda for the shortage of time. Dr. Reda, are you ready? Yes. We don't hear you yet. We can see your screen, but we don't hear you.
Dr. Reda, please unmute. Dr. Reda, please unmute yourself.
Now?
Yes, we can hear you.
Yes, we can hear you.
Okay. You hear me? Okay. We'll start because we have a lot of time.
Indications of surgery for GERD. Yes, please.
Okay. Bismillah. My talk today is concerning the indication of surgery for GERD, which all of us know represent a big conflict between surgeons and our gastroenterologist colleague. We know GERD is a common problem affecting about 20% of the population, and it is the refluxate or of the gastric content, whether being gastric or alkaline, sometimes with symptoms, sometimes without, sometimes with endoscopic change, and sometimes without. The problem in GERD is it is surrounded always by dilemma. Dilemma in the presentation, because the patient sometimes present with the typical presentation, sometimes atypical like cardiac or respiratory, and sometimes presents with complications like adenocarcinoma. Also, you have dilemma in the diagnosis, even if we use all the modalities of investigations like the endoscopy, the dye study, the motility, the pH-metry, still some cases we couldn't reach a definite diagnosis. Also, the most important is the dilemma of treatment, because we have different modalities for management, like the medical and the surgical and the emerging endoscopic techniques. Simply, gastroesophageal reflux disease is a barrier problem. We know that the esophagus is surrounded by its lower end kept content by many factors representing what is called the barrier mechanism. These factors, the most of which is the lower esophageal sphincter, which is the high pressure zone between the esophagus and the stomach. Other factors are the diaphragm with the Pinchcock mechanism, the very important abdominal segment of the abdominal esophagus, which is submitted to or subjected to the intra-abdominal positive pressure. Phrenoesophageal membrane or ligament is a very important factor in keeping the competence of the cardia, the angle of Hess, and the configuration of the esophageal mucosa. All these factors share together to keep the cardia competent and prevent the occurrence of reflux. The available modalities for treatment now, we have the medical treatment, and again, I am saying that medical treatment is the keystone, is the most important line of treatment of GERD associated with lifestyle modification. We have other lines of treatment, the endoscopic maneuvers and the surgical management. If we compare the PPI, which are very strong drugs, it can provide symptom relief in most of the cases of reflux, but still in some cases, which are called the refractory cases, representing about 30 to 40%, still are resistant to PPI. What we notice nowadays are some changes in the growing number of reportation due to the long-term use of PPI and a increase in laparoscopic fundoplication after its decline. We know that there was the last decade decline in the incidence of laparoscopic fundoplication because of the era of bariatric surgery. Nowadays, we have a rebound increase in the number of surgery. And now the emerging endoscopic techniques. We have many endoscopic maneuvers or techniques like the TIF, transoral incisionless fundoplication, the strata, which is radio frequency delivered to the lower end of the esophagus, the LINX, which is the magnetic links, the endosteam and the stem cells. But if we comes to the papers and the publications, we found that if we compare the three modalities, we found that laparoscopic Nissen fundoplication having the greatest ability to improve both the physiological and the structural parameters of GERD. So increasing the lower esophageal pressure and decrease the time of the esophagus affected by the pH less than 4. Also, many of the publications now showed that all these modalities are temporary. We can't use them as long-term management of GERD. We know GERD is a long-standing disease like diabetes, like hypertension, and the patient should take or should have treatment for the whole life. So these techniques are limited time, and they don't recommend a long-term alternative to the medical treatment or the surgery. So, as I said, we have a rebound increase in the number of anti-reflux surgery. One of the main factors is the laparoscopy, because the laparoscopy makes the field very clear, the hiatus is very clear, and so the dissection and the repair is very easy. Besides, as I said before, the publication nowadays about the side effects of PPI. What we do in surgery is two simple steps to repair the crura, to correct associated hiatus hernia, and to make a wrap or valve around the lower esophagus formed from the uppermost part of the fundus. The problem in this operation, it is a functional operation. It is not like cholecystectomy, appendectomy, just after removal of the organ, everything is set. No, this patient will be subjected to complication if this operation was not done perfectly. So we have many tricks in this operation. As we hear, every step should be done in a perfect way, and better to be done by an experienced surgeon in high volume center, like in our department of upper GIT surgery. Because if not done correctly, the patient will suffer from complication post-operatively. Surgery, if we know about, or the publication now, if we compare it, is the more effective than patient relevant outcomes. So no way, if we compare surgery to medical treatment, surgery, of course, is having the best result. But what are the indications of surgery? We have about go quickly. Refractory GERD, of course, is the first treatment, first indication. About 30 to 40 of patients having GERD don't respond to PPI. So we have to reconsider the lifestyle of this patient, compliance, and to redo all investigation to reach sometimes to this fact that some of these patients having hiatus hernia, sometimes having low esophageal sphincter, alkaline reflux, and by doing surgery for this patient will improve, are no more refractory to treatment. They are refractory to medical treatment only, not to associated hiatus hernia. Very important fact that GERD is, we know that it is a functional disorder, but if it is associated with hiatal hernia, so by hiatus hernia development, all the components of the barrier are compromised, are absent. So only surgery will revert back or correct these factors and turn back the cardiac content. If the patient having regurgitation, we know that the lower esophageal sphincter and the hiatus hernia are usually associated with this regurgitation, and only surgery can increase the lower esophageal pressure and correct the hernia. Young age are now, okay. Young patient is now considered as indication of surgery because, as we know, the complication associated with long-term use of PPI. The development of complication, we know, are now settled. Even the Gastroenterologist Association changed their guidelines, and the need for chronic PPI should be evaluated on a regular basis, and alternative options should be sought out in patients with high risk for PPI. Some countries restrict the use of PPI to patients above 65 years. Cost is also, these drugs, the PPI, are very costly and very expensive, and sometimes surgery is more cheaper. Develop application on top of Barrett, and of course Barrett esophagus, and is a precursor of adenocarcinoma, and this is a long history, long story. It is not the time to discuss, but if the patient having Barrett, surgery is indicated. Alkaline reflux, of course, because PPI will not do anything about biliary reflux, so it is also an indication of surgery. Lower esophageal sphincter, low pressure or incontinent, so only surgery is the one who can augment the drugs. Even if I will take 60 times a day, it will not increase the pressure and correct the lower esophageal high pressure zone. Only surgery is indicated in cases of cardiac. Sometimes I have to go to do cholecystectomy, so better to do associated hiatus fundoplication, but not the reverse, not to do cholecystectomy without the fundoplication. So GERD is a barrier defect, anatomical problem. In 90% is associated with hiatal hernia. There is refractory patient in up to 30 to 40% taking PPI. We are calling them non-responder. There is risk documented now of PPI complication in long-term use, where this association, the Gastro Association, has changed their recommendation now, and the PPI should not take for long-term in patient having problem like age or having deficiency of some elements. Barrett is also a documented complication of long-term reflux, and we know its progression to adenocarcinoma is a fact. So only surgery can restore the valve action and correct the problem of reflux. So we have to expand the indication of surgery. It is justified. And I am always saying that GERD should never be considered as a medical treatment. It is a disease, should be managed by surgeons, but not by surgery. And there is great difference. I am saying surgeon is the one who can deal with the case, but sometimes he can deal by medical treatment. So what I am advising is to do what is called MDT, including the surgeon, the gastroenterologist, the radiologist, physician doing the pH and the manometry, and to discuss each case individually and to choose what is best for this patient, whether medical or surgical. Thank you.
Thank you, Professor Dr. Reda. This is actually a very big topic. You managed to present a very concise part, but the message is clear. Surgery is having a major role now in controlling of this disease. And I think for the two presentations, whether this one or the one before, there is still surgery is the main part, and endoscopy is actually all the methods, whether for the achalasia or for the reflux, can be an adjunct, not a substitution of surgery. I think that when we are doing Heller myotomy, for example, we can use the endoscopy as a guide, and we can use here the endoscopy for follow-up after GERD and so forth. But still, surgery is the mainstay of these diseases. Any questions from the audience? Because we are short of time, and I will have to present after that a promotional session. I hope you all stay with us to see this promotional session. Any questions? Do you see any questions, Professor Reda, for you?
No.
Okay. Okay. Thank you very much, everybody who participated. And I will have to present now Engineer Mahmoud Abdelrazek from company Maquet. He is going to present a promotional session. We see what he's going to present for us. Thank you very much, everybody.
Professor Hisham, getting lecture is being postponed, and may we introduce Professor Mohi Al-Banna to present Dr. Karim.
All right.
Professor Mohi.
Here. Hello. It's very good presentation, Professor Reda. Thank you very much. We joined a little bit late, but it's great to see you online and to listen to your lecture. And now it's my pleasure to introduce our colleague, Professor Dr. Karim Sabri. He will be presenting his work on the management of hiatus hernia in the bariatric surgical patient. Professor Karim, please.
Hello. Hello, everyone. Test for voice.
Yes, we can hear you clearly.
Okay. Thank you, Professor Dr. Mohi Al-Banna, for helping me and inviting me to present this talk today. And he helped me a lot yesterday to represent this topic today, because we have some technical issues yesterday. My presentation is about how to deal with hiatus hernia in morbid obese patient, and I want to produce different strategies how to deal with hiatus hernia in a morbid obese patients. This is my disclosure about how I can practice about 50% of sleeve, then MGP about 20%, then Roux-en-Y, and then redo surgery. Goal of this presentation to find different strategies how to deal with hiatus hernia in a morbid obese patient candidate for bariatric surgery. We know all that hiatus hernia is very common in morbid obese patients. About 50% of patients has a hiatus hernia, and about 11% has asymptomatic hiatus hernia. This video shows how we can see different types or different sizes of hiatus hernia. Some patients presented with barium meal that shows a hiatus hernia, and others may present asymptomatic hiatus hernia, and you can find it intraoperatively without pre-investigations. And usually here in our practice, most of surgeons don't do routine endoscopy pre-operatively. So you can find it as an incidental finding with your patients in daily basis. Sorry for this voice. This different size, what can you do? You will do a sleeve gastrectomy if you promise the patient that you will do a sleeve, or you will convert it to Roux-en-Y gastroplasty, gastric bypass as a solution for that case. There's also a different sizes, a different hiatal hernial as hiatus hernia. There's small hiatus hernia, there's large hiatus hernia. What can you do in that cases? We choose 3 applicable strategies to do something with the hiatus hernia in morbid obese patient candidate for sleeve or bypass surgery. We started to do a cruroplasty only in a sleeve gastrectomy, or to do sleeve gastrectomy with ligamentum teres augmentation, and some cases we converted to Roux-en-Y gastric bypass. But some literatures support that you can convert it to mini gastric bypass, and I will share with you this review of literatures. And also they support to do sleeve gastrectomy with cruroplasty with mesh, and also some surgeons support by literature to do nasal sleeve, and that usually carries a high percentage of leakage. Our protocol in management of hiatus hernia, actually in my practice, is to divide the group of patients, morbid obese patients with hiatus hernia, into 3 groups. The first group will do cruroplasty with a sleeve gastrectomy. If we find that the hiatus is a small hiatus hernia up to 5 centimeters and the patient is asymptomatic, but the pillars is very good, and the pillars is can withstand sutures to augment it without tear. I mean the good pillars, good hiatal muscles, and also the hiatus can withstand attention-free stitches. In these cases, in these instructions, we can do sleeve gastrectomy with cruroplasty only, without augmentation. The second group, if you find that there is a small hiatus hernia up to 5 centimeters and the patient is asymptomatic, but we found the crura is very weak and the pillars is very weak, and if we find also there is attention stitches, we can augment the crura after cruroplasty with ligamentum teres sling. And also the third option and the third practical maneuvers to do is to do cruroplasty plus Roux-en-Y gastric bypass if we found that there is any degree of reflux and the hiatus is more than 5 centimeters and there a complaint from Barrett esophagus, or the patient coming complaint from Barrett esophagus. This is the first technique or the first option to deal with hiatus hernia in a morbid obese patient, is to do the usual repair, the usual dissection as anyone can do. Before we start to do sleeve gastrectomy, we can dissect the hiatus. We can make a satisfactory length of the intra-abdominal esophagus about 4 to 5 centimeters intra-abdominally. Here, in this case, we find that the crural muscle is very good. The crural muscle, the pillars is very good, can withstand stitches, as we can see now. So in this case, we repaired the hiatus by doing cruroplasty only, by a couple of stitches in the posterior the posterior stitches, a couple of stitches in the posterior pillars, and we can take one stitch up anterior. Then complete our sleeve gastrectomy as usual. And this is my technique also to do augmental fixation for all sleeve gastrectomies. This is the first way that I manage hiatus hernia with in morbid obese patient. The second technique, or the second option, is to do sleeve gastrectomy with cruroplasty with ligamentum teres sling. After we finish the cruroplasty as usual, if you find that the hiatal muscles is very weak, we can take the ligamentum teres, as we can see now. We can separate it from the anterior abdominal wall, starting from the umbilicus, reaching to its origin, to make it completely mobilized and easily mobilized. We can cut also to make it easily mobile. Then take the ligamentum teres and make it behind the hiatus and make a sling by it by this ligamentum teres. But nowadays I don't do this complete wrap. I make also the support by this ligamentum teres behind the hiatus, and no need to make a sling, because we based on the serosal reaction behind the hiatus and not for the mechanical one. Make sure that you don't do a sling, a twist for this flap to avoid strangulation. And this is a complete rape. It's not so tight, but nowadays I don't do this complete sling, because again we are relying on the serosal reaction behind the hiatus. This is the second technique. This is the third one. If you find this dysplasia or esophagus, or the hiatus very large, or the patient complaining from severe reflux, we can do conversion to classic Roux-en-Y gastric bypass. This ongoing study, as we can see, as usual, we can dissect the hiatus. This is the posterior vagus, and this is the pleura. We can dissect as usual, and convert those group of patients to Roux-en-Y gastric bypass. After cruroplasty, we have to finish the pouch formation. This is how we can fix the cruroplasty, or to complete the cruroplasty by Prolene to 0. A couple of stitches behind. On a 36 French bougie as a calibration tube, but we have to be lax because this bougie is very small. Here's how we can fix the gastrogenostomy and the enteroenterostomy. And this is the last step on doing Roux-en-Y gastric bypass. Hiatus hernia in morbid obese patient is a controversial matter. Review of literature. A lot of papers support every technique hiatus hernia repair chloroplast only with a sleeve. We can find a lot of papers support that. Roux-en-Y gastric bypass, a lot of papers support that. For sake of time, I will let these papers on the presentation. Anyone can revise it because this is a lot, but we can conclude that we have to do a multicentric studies to support the small number of studies that support each of the previous procedures. I'm not with or against any procedure. We will publish our results soon, inshallah. Thank you for your attention, and if there is any questions, I will be happy to answer about it.
Thank you very much, Professor Karim. Very interesting presentation.
Thank you.
It's very important that you pointed that the bougie we use for sleeve gastrectomy or Roux-en-Y gastric bypass is smaller than the usual bougie we used during Nissen fundoplication. When we started Nissen fundoplication, we used a bougie 56 French. But we do the sleeve or the bypass on a bougie probably 36 or 38. So this is a very important point. One very important point is that you presented me a video on partial wrap over a mini gastric bypass.
Yes, sir.
So I need you to talk about that management of hiatus hernia with bypass, because this is very interesting. We were very concerned with hiatus hernia and reflux with sleeve gastrectomy, and now we are interested in dealing with hiatus hernia and reflux with gastric bypass too.
Yes. Sir, I quoted this procedure from you, and I tried to apply it by doing a wrap behind the crura in the patient's candidate for mini gastric bypass. Some patients actually coming asked me to do mini gastric bypass. He didn't want to do any other procedures. But we find some patients have reflux, grade A or grade B reflux, and I fear that in the future they can get in the future severe reflux later on, and I will blame myself. So I quoted this procedure from you, sir, because to take a wrap behind the hiatus to prevent bile reflux. But in this case, the patient, I tried to use a very simple way to make it very simple, to try the basics of general surgery in the past about Nissen complete rape, or to be rape to avoid more dysphagia in the future, and to avoid more problematic symptoms later on about dysphagia and eating problems. So I tried to use a simple rep, and I feel that it is very simple, not it is very easy, technical. You don't need to make a very large segment of devascularization about the fundus. You can take in 2 to 3 minutes, and its fixation is very very good. Inshallah, in the future, I will do it in any patients in mini gastric bypass who is complaining from any degree of reflux in the future. And I will study it, and I will share with you, sir, this technique and its results, inshallah.
It's very important to highlight the fact that still there is reflux with or after gastric bypass. The gastric bypass is not 100% proof against the occurrence of gastroesophageal reflux, not only biliary reflux. So yes, maybe in a small percentage of patients, we need to add an anti-reflux procedure, whether complete wrap or partial wrap, to the gastric bypass, whether it's Roux-en-Y or mini gastric bypass. This is very important. I'd like to thank you for one other point, that you differentiated between hiatus hernia and reflux esophagitis. They may be associated, but there are a subset of patients who have hiatus hernia without reflux, and some patients who have reflux without hiatus hernia. Yes. And the management is different. If we have reflux esophagitis grade B or more, probably we need to do a bypass, not a sleeve gastrectomy. So we can do sleeve gastrectomy with crural repair in patients who have hiatus hernia, but not a high grade of gastroesophageal reflux. Yes.
Yes.
Any comments?
Thank you, sir. But I would ask a couple of questions on the yesterday lecture of you on the metabolic surgery. If you can let me to ask, what the lowest, what is the lowest body mass index you operated on to do metabolic surgery for this diabetic patients? And also
actually.
Okay, proceed, sir.
Yes,
go ahead. And also,
well,
okay. Go ahead, sir.
Well, I did metabolic surgery on patients with BMI 32 plus diabetes mellitus or other metabolic disorders. And the results were very good. I was even surprised that many of the patients who undergo metabolic surgery, when they have early diabetes and a low BMI, they get very good results, a very good metabolic outcome of the procedure. So I was very reluctant at the beginning to do bariatric surgery for patients who have BMI less than 35. And now I'm not that hesitant when I get a patient with BMI 30 or more with a metabolic syndrome. I advise him to undergo a metabolic procedure, starting from sleeve gastrectomy on. But of course, I do not do an aggressive metabolic procedure for low BMI patients with metabolic syndrome.
Okay, and the second point is to I want you to invite all the internal medicine doctors and to share with us how we can deal with the metabolic surgery, because we found nowadays there is a severe resistance from them to do or to get the advice for the patient to do metabolic surgery. What can you say for them?
Well, you are right about that because we were talking in the past about cure of diabetes, but endocrine professors and our colleagues, endocrinologists and diabetologists, they say that diabetes cannot be cured, that patients can only remit, can benefit from a remission of diabetes mellitus. But now we have many studies that talk about long-term remission of diabetes mellitus, and even if the patients have a relapse of diabetes mellitus, at least we can buy them time. The patient gets a remission for a number of years, maybe 5 or 6 years, and then maybe his pancreatic reserve fails and he gets diabetes again. And still, we postpone the incidence of complications of diabetes, and we know how horrible the complications of diabetes can be. Well, I know my presentation mainly highlighted the fact that many endocrine societies and diabetes societies now recognize metabolic surgery as a pivotal step in the algorithm of management of type 2 diabetes mellitus with metabolic syndrome, with obesity. And I think it will take some time, but we know that patients now are, many more patients now are convinced. Many more patients come to us for metabolic surgery when they have type 2 diabetes with obesity. It's we are now much more better than we were 10 years ago, and probably in the next 10 years we'll see more advances and more progress, and more of our colleagues convinced of the value of metabolic surgery.
Okay, sir. Thank you for this great presentation yesterday, and thank you again for inviting me for this session. And I hope we can get the points today.
Yeah, thank you very much. Thank you. Thank you, everyone, and see you later. Thank you.
Shukran. Thank you.